All right. So, so shock. I'm going to try to give you the high points to write down. The biggest things I just need from you guys in general. Shock is hypoperfusion. That's what that is. Shock is simply the body's inability to have, possess, and transport enough oxygen and nutrients and remove waste from the body. When you were taught at an EMT school, shock was simply we just didn't have enough oxygen. Now, again, thinking a little bit higher level, we know that not only do we need oxygen, but we need all that potassium and we need that sodium and we need all that other stuff to get into the body. If that doesn't get there, we don't have the ability to function on a cellular level. Conversely, the waste, it takes energy to make all this magic stuff happen. So to get the waste out of the body is pretty important. If you don't have the ability to rid the body of the waste, you end up having that buildup, and that buildup turns into basically acid. So when it turns into acid, you end up being acidotic. So again, hypoperfusion, there's several layers to it, and it's not just you just don't have enough oxygen. But at the base, if anybody has ever asked you for a definition for shock, this is exactly what it is. It's a body state of hypoperfusion, and that at its core is exactly what it is. Now, naturally, we'll talk about some of the compensatory mechanisms and some of the things that the body can do. And again, I'm trying not to spend a whole lot of time on this, but if I need to slow down or speed up or something like that, I know that I'm totally open to hearing this stuff from you guys. All right. So when the body notices it's in shock, and there's a couple different variations to where and how that typically works. And we'll talk again some specifics with the shock kind of as we go through them, the different types of shock. But just know that once the body identifies that we're in a state of hypoperfusion, it's going to go into this whole systemic chain of reaction. Things like the catecholamines. It's going to go through, and basically the body is going to try to start fighting that. It's going to try to, it notices that we don't have enough oxygen, so it's going to try to ramp up the oxygen. The only way it knows how to do that is to breathe faster and to beat your heart faster. So both of those things combined allow you to kind of move into that state of preparedness to try to stock up on oxygen that you might not otherwise have. There's going to be some fluid shift stuff, because if the body doesn't have perfusion, if it doesn't have what it needs, whether it's fluid, oxygen, or the natural ridding of waste, it's going to try to flush it. That's one of the big ways the body tries to work with that. So we'll talk a little bit more about that here in a minute. And some of this stuff I'm going to kind of skip through because again, it's not super helpful. But what is helpful is understanding that when your body doesn't have that oxygen, each body system operates a little bit differently. So as far as the organ systems are concerned, each organ can tolerate a state of hypoperfusion a little bit better or worse than its counterparts. The brain, for example, the brain doesn't do well. If you don't have oxygen in the brain, you don't have consciousness. Those go together. If the heart doesn't have oxygen, you don't have a heartbeat. That's relatively important. So some of these things our body can compensate for. If our kidneys don't necessarily have what it needs as far as a blood flow or blood supply, it can kind of figure it out for a temporary period. But overall, some of the more vital organs just can't necessarily do that. So our body does a good job at keeping up while it can, and then it'll stop when it finally has just had enough. All right, so shock. Here's the big thing with shock. And if you're writing stuff down, there are two main types of shock. There's a central shock, and central shock that consists of the cardiogenic shock and the obstructive shock. And we'll talk about some of the obstructive shocks. And then there's peripheral shock. And the peripheral shock that's like the hypovolemia and the distributive and sepsis and some of the other things that we normally think about. So again, shock is basically an inadequate oxygen supply, and that can happen by way of either of those two categories. Without that stuff, we know that the cells can't do what the cells are supposed to do. We know that the body can't necessarily function appropriately. If the pancreas and the gallbladder and all that stuff doesn't work, then digestion slows down, glucose release changes. Pretty much everything starts to change until it gets it back. So here's our two types that we just talked about. And getting into some of that, so cardiogenic shock is basically the heart cannot circulate enough blood. Somebody give me an example of this. What is cardiogenic shock? Give me a disease. Give me a problem. Anybody?
Sorry. Tamponade. How do you say it?
So I heard MI, I heard cardiac tamponade. Both of those are correct. So an MI, so a heart attack. If the coronary arteries don't have enough oxygen to beat, it's going to start killing the tissue. As that tissue dies, the heart can't contract anymore. That's cardiogenic shock. You can't move blood. So this is inherently a pump problem. So the pump is not physically beating. Now, why is the pump not beating? Does it not have enough volume to pump? Is the pump itself broken? Usually it's something very specific to the pump itself. So the picture you're seeing here is the top one is just an utter train wreck is what that is. All the yellow is fatty tissue. So this could be some host of God knows what. Blue, that bluish color, a lot of times that is truly a good picture of ischemia. So, this particular patient, that heart has no blood flow at all. That's apparent just by the picture. So obstructive shock is basically some type of blockage. It's basically it's a blockage, whether it's a blockage of some of the major vessels, whether it's a blockage in peripheral vascular, and we'll talk about some of that stuff also here in a little bit. But a lot of times that has to do with there's some aortic problems where the aorta can actually split into basically there's a small tear in the first liner of the aorta. So each vessel has a bunch of different layers in it. If the first layer starts to break and there's some kind of laceration or something internally on the inside of that aorta, blood flow can kind of flow back behind the two layers, and that's called a false lumen. Or a dual lumen, and that's basically just a fancy term for saying blood flow is not going necessarily where it's supposed to be going. So that's one of the big options, or one of the big things for obstructive shock. The big one that you're going to hear is a pulmonary embolism. So if a big blockage or something happens somewhere in the lungs or somewhere down in the bronchial tree, that is an obstructive shock where basically blood flow prevents, or something is preventing the blood flow from getting into where it's supposed to go. So peripheral shock, and again, moving kind of fast. Peripheral shock is just not having enough volume. There's not enough fluid in the tank to keep the body going. And if there's not enough fluid, then there's not enough blood, because there's not enough red blood cells and hemoglobin to carry all of that stuff to the cell level. So there just isn't. We know that there's external bleeding, there's internal bleeding. We also know that on a cellular level, we have the ability, our bodies have the ability of being dehydrated without even having blood involved. And again, we talk about like burns. Burns are a big one. We talked about how much of our body's fluid system is actually held within the cell walls. If the cells are burned, or the cells are damaged, or the cells are non-existent, then naturally neither is the fluid that's supposed to go with it. And if there's not enough fluid, the body's going to find a way to try to shunt more fluid to backfill that area. Well, as you backfill that area, then you're taking main fluid from the tank. So again, hypovolemia can manifest itself in a whole bunch of different ways. So, but hypovolemic shock at the core, your blood is no longer where it's supposed to be. It's either on the floor, or it's in a pelvic cavity or abdominal cavity, or somewhere else where it shouldn't be. This is one that we're going to spend a lot of time on as we move forward. Distributive shock is a very, very strange, sometimes hard to diagnose, difficult thing. Basically, it can be any host of these three things that you see here. Well, those three things don't appear to be, they're not really related. So either I'm allergic to something, or I have an infection, or my brain's messed up. But at the end of the day, all three of those result in the same thing. So sometimes it's kind of difficult for us to be able to identify which one is which, and the treatment pathways for all three of these couldn't be further from the same. So, but knowing that basically this peripheral distributive shock is a widespread dilation of vessels. In a few minutes, we're going to talk about why that happens and what's responsible for that. And that's about as deep into the cellular world as I want to go today. And Monday, if I didn't hear Monday, but if I had to guess, you guys probably went pretty deep into the cellular stuff. You went pretty deep into the $4 words, and this is just me guessing, because I know the players. She is brilliant when it comes to this stuff. So I'm gonna try to make this very, very surface level, so that we can both understand it and be able to physically use it. Because I don't necessarily think that we're going to be doing a bunch of lab draws in our basements. So this is going to be pretty much what we need to know from a practical sense. But what you do need to know for testing is that these different types of shock exist, and you're going to have to know how to identify the individual ones. So a cardiogenic shock, what does that look like? How do you figure that out? So we know that their blood pressure is going to probably be low. Their heart rate's going to probably be high. Their body's going to be trying to compensate the best it can. And then underlying, we're going to find either a cardiac event, or we're going to find some thoracic trauma, something, a horse kick to the chest or something. And that's going to lead us into it being some type of very isolated, issue. So if it's cardiac, we can fix that, or we can start to fix that. If it's the obstructive one, we can't do anything about that. There is nothing that we can do in the back of the ambulance to fix an obstructive shock. They need either shock, or they need stroke treatment. They need some kind of surgical intervention. So that is something that we might be able to identify it. We might not. We can absolutely identify all three of these. So we're going to spend a lot of time in medical when it comes to these. Anaphylaxis is something that's killing a lot of people, and it's something that we absolutely can prevent. So there's absolutely no reason. More than anaphylaxis, sepsis is killing all kinds of people, and we miss that on a regular basis. As hospital providers, the number is 80%. So 80% of the people that have sepsis are treated at some point by EMS. So think about that for a sec. If sepsis is one of the leading causes of death for elderly people and for people in general, which is not the top, but it's pretty high up there. And I can tell you that 80% of them have passed through your hands at some point. That's a pretty big deal. So for us to be able to identify that and properly notify the hospital and properly get the ball moving for that's pretty important for us. And 10 years ago, sepsis wasn't really a thing. Like it was, but it was this weird thing where, these people just chose not to get treated, or they chose not to take their antibiotics, and they end up dying. We know now that that's not really the case. We know that grandma that has a urinary tract infection in 4, 5, 6, 7, maybe 10 days can be literally dead from that urinary tract infection. So it's not necessarily the urinary tract infection that got her. It's this systemic, widespread dilation of vessels that prevented blood flow from getting where it needed to go in the body. And that's what we're focusing on. That's what we're getting after here. So as far as management, what is the EMT basic management for shock? That's a
oxygen, warm, and elevate legs.
Yeah, keep them warm. You can elevate their feet if you want. And again, we know from an EMT world, again, the lower level thought, we know that we elevate the feet because we memorized that that's what we're supposed to do. Well, if I go back a slide and showed you that peripheral dilation of the blood vessels is what shock is, or what distributive shock causes, then by us elevating our legs, or the patient's legs, we know that we're just trying to use gravity in that dilated state to let all the blood flow run back into the core. So that's why we do that. I know we memorize it, but that's why we do it. We know that there's probably a hypovolemic state at some point in some of these, whether the oxygen physically can't make it there, or the oxygen physically, there's just not enough fluid, or whatever the case is. So when we give oxygen for the shock patient, we're doing that to try to make sure that every piece of red blood cell in the body, every hemoglobin, has oxygen attached to it. So we give that oxygen to make sure that happens. And then we keep them warm because we've determined that if the body's cold, the body starts to slowly metabolize, and the metabolism starts to slow down even greater. So what happens is your body doesn't use what it has because it goes into like storage mode. So we know that keeping a body warm, we know that stimulates the body to continue to pump and function appropriately. So it's not just keep them warm, elevate the feet, and give them oxygen. This is exactly why we do it. And that's what's kind of important to understand for us, because if there's an absence in one of those, if we don't give oxygen, we know what's going to happen. We know that their O2 saturation is going to go down. We know that as that goes down, we know that their carbon dioxide will start to build up. We know that starts into this major cascade of essentially death. You can write this down if you want, but every single patient that dies by way of shock. So whatever the cause is, they go down through whatever the pathway is that's causing their issue today. Left untreated, will start to turn into shock, and shock will ultimately lead to death. So there's no real way to get to death without going through some phase of this shock. So there's some very, very finite splitting hairs examples where maybe it does, but most of the patients that we're going to deal with that do die, they die by way of shock. And then we're just trying to beat feet to get ahead of whatever that particular issue is at that particular time. So some of the signs of shock. They're right here on the screen. So modeling is like that blotchiness of the skin. Pallor is like a kind of a gray, they're just kind of like an ashen. They just look unwell, and that's really what that's the best term is, unwell. You can see them from the door. They look sick. They're probably pale or something. They're sweaty. So the peripheral or the central cyanosis. Naturally, peripheral cyanosis that's bad, but that's not quite as bad as central. So if your core is blue, that's no bueno. That's no good. And then cap refill. Cap refill is garbage, if I have to be honest. There's elderly people have terrible cap refill. I know textbooks say the kids have good cap refill, but it's hard to tell. It's hard to tell. You can't always use that. But that's the clinical us trying to figure out what shock is. That's some of the big tip offs there. ETO2, we're going to talk a lot about end tidal. And I don't want to get too deep into this now, but we know that end tidal is physically, it's your monitor literally calculating how much carbon dioxide is in the exhaled breath that you're breathing. That's going to be useful for, I promise you, just about everything. It's some way, shape, or form, end tidal is going to be useful for us to be able to treat and determine the problem. So going through why, let me ask the question, why, if I'm telling you that shock is somebody's body hypoperfusing, and they may or may not be breathing well, which means they're probably retaining oxygen, why would we see decreasing levels of end tidal? Anybody? Nobody?
Is it because oxygen and EtCO2 are directly related, so the less oxygen you have, the less EtCO2 you'll have come out?
Yes and no. So if you bring in the oxygen in your body, if a respiration cycle, so you bring in the oxygen, the magic happens in the alveoli level, and you exhale the carbon dioxide. If you're doing that equally, so a breath in, it's doing what it's supposed to do, and a breath out, that breath out should be 35 to 45 millimeters of mercury. That is the appropriate end tidal range, 35 to 45. So if that starts to drop, now this is where we get really, really confused, and this is something I struggled with for a while. If I told you that a pH drops, a pH is low, are they acidotic or basic? So if the pH goes down,
Acidotic.
you're alkalotic. What is it?
Acidotic.
You're acidotic. If an end tidal goes down, are you acidotic or alkalotic?
Alkalotic.
Alkalotic. That's tough. That's tough to think about. So again, the lower the pH number, the more acidotic you are. But end tidal, if I'm telling you that this is measuring the acid coming out of your body, if I said it in those terms, if I'm blowing out a lower number of acid, then it's a lower number of acid. You're on the alkalotic side. You're not acidotic. You're not retaining because you're blowing it off. So the reason you're going to start seeing this is that this is all going to go into the immune system and in the body's compensatory system. But if basically the first thing our body's going to try to do is it's going to try to fight. And as soon as it starts to fight whatever this issue is, it's going to, as this compensation happens, you're going to end up, your vascular system is going to try to constrict, to try to increase the blood pressure. Your heart's going to beat a little bit harder to try to increase that blood pressure. It's going to beat a little faster to try to ramp up the delivery of all the white blood cells and all of the oxygen and all of the stuff that it needs to get to the tissue. And it's also going to increase your ventilatory rate. So as your ventilatory rate increases, you're blowing off more CO2. And as you blow off more CO2, that's going to start dropping your end tidal here. So that's one of the main reasons you're going to start to see this early indicator of a lower EtCO2, because the body is trying to fight. The body is trying to, you're breathing fast. So being tachypnic is one of the big indicators for that. Specifically with sepsis, everybody's going to be panning. They're going to be breathing really, really quick. Anytime you've had a fever, if you think back to your fever, part of what makes a fever uncomfortable is your body aches all over the place because it's literally trying to store as much fluid and white cells in the tissue as possible to try to fight this, and you're breathing fast. So most of the people that have, anybody that you run on that has fevers, they're probably going to have an elevated ventilatory rate. And the last one is, so if I have a patient that's got a pressure of 80/40 and their end tidal is 12 instead of 35 to 45 where it's supposed to be, that's scary. So we're starting to have multi-system issues now. So their blood pressure is not able to keep up. Their ventilatory rate is doing something to further harm themselves. So this is like I said, end tidal is going to be a big thing that we're going to use a lot of. I know Brenda talked about mods. Basically, all I need you to know about this is that either there's a direct relationship. So literally, somebody got kicked in the chest by a horse, and everything related to that chest cavity is now affected, organ-wise. So that's something very, very specific. Another specific for mods would be like a cancer or some kind of tumor or something that affects one specific quadrant of the stomach. That obviously would create a pretty significant issue for several different organs. And then otherwise, there's a progressive issue, and the progressive issues, the secondary ones, this is like your long-term chronic patients that we're not going to deal with too heavily. These are going to be like dialysis patients. These are going to be patients. It could be the cancer patients that have like a leukemia or like a widespread cancer of some kind that slowly start to deteriorate organs. And both of these are, don't get me wrong, these are awful. But there's really not a whole lot that we're going to be able to do specifically for them, other than treat the shock that's going to come with this. And I'm going to skip through some of this stuff. All right. So the immune system and how this relates specifically to shock. So everything we talk about today, think about it in the terms of shock. So and I know there's a bunch of different types. So we'll kind of link them back together kind of as we go. But know this, know that the immune system, basically it is all the structures, all the processes on a cellular level, on a physiologic level, pretty much the entire body system, and how it associates the corrections for any defense mechanisms. So basically it seeks and destroys. It finds a problem, it releases some magic stuff that goes out there, it sends the soldiers out to bind to it and kill whatever that antigen is. And as we move forward, that's going to be kind of important to understand. So the body, these are the three different ways that it's going to try to defend itself. There's going to be, first of all, the skin. The skin is going to try, the pores, things like that are going to try to minimize the absorption of whatever an external issue would be. The inflammatory response is your body's way of saying, hey, I'm going to send all the blood, I'm going to send all the nutrients, all the stuff to this cell, to this capillary layer. And within that is going to be all these white cells. And the white cells, we'll talk about that in a little bit, but the white cells are what physically create the magic of actually mitigating the body of whatever it's trying to fight off. And the immune system is exactly that system. It's that system that goes out, searches for the problem and destroys it. So as far as the anatomic, we're not going to spend a whole lot of time on this. Basically, this is the basic stuff that tries to stop the thing before it gets in there. You know that. Moving into the immune system, this is where it gets kind of deep. What you got to know in this, and if you're, as we go through this, it might be beneficial right now if you want to take a note for me. If you make two columns, if you're taking notes, otherwise just kind of hang tight and listen. But make two columns on a piece of paper. On one side, you've got allergy and an allergy response, and on the other side, you've got a virus or bacteria and whatever related illness goes with that. So within that, on either side, probably on the virus side, in order, you can put T as in Thomas, T cells, and then B cells, B as in boy, B cells, and then mast cells, M-A-S-T cells. So all this is more on the virus bacterial side. Now on the allergy side, it's a lot easier. On the allergy side, there's IgE, and then below that, there's mast cells. And we'll go through and figure out how to link all that stuff together in your brain here as we go. As you go through the book, if you look, you can get lost with all these chemicals and all these cells and all these names and all this other stuff. And I can't necessarily say that it's not important, but what I can say is that there's definitely some that are more important than others, if that makes sense. And that's kind of what I'm trying to focus on here. So as we go through, we'll refer back to what you just wrote down. So white cells, we know that white cells that floats around the body. We know that the white cells carry basically it's the lymphocytes. It carries the immune system. It carries the antibodies that your body has created to basically fight off. This is essentially at the core. This is your immune system, is these white cells. The problem with the body, and we'll get to talking about this here in a little bit, those mast cells that you wrote in both columns, that is what physically tells the body to retain fluid and to start to swell. So as we move forward, white cells are phenomenal, but they activate these mast cells, which causes inflammation and swelling, which is not so phenomenal. So that's kind of where we're going to start. We're going to start tying all of that together. So bacteria enters the body. Basically, the cell wall says, hey, there's this thing here. We're not really sure 100% what it is, but there's this thing here. We're not real sure, but we don't like it. We're not a fan of it. So the membrane, basically the cell, they come up with this, they call it a complex in the book. And the complex, basically all we're talking about with a complex is there's the bad thing in the body, there's the good thing in the body. So our antibodies, like the antibodies that our body actually creates, and the bad thing in the body, they go out, they find each other, and they bind together. That's the complex. The complex is our defense, and whatever the intruder is, bound together, creates this complex. And from there, the white blood cells finds that complex and destroys it. That is literally what our immune system is doing on a very, very surface complex level. So when it comes down to these B cells and the T cells, if you wrote them on your paper, so basically the T cells, they are the screening cells. The T cells are the TSA. They are this group of cells that literally just forms these little checkpoints throughout the body and decides whether or not there's an intruder or not. These are the frontline. Basically, they're the top level of kind of the oversight for the body. So TSA. So they're screening everything that goes through the body. If it finds a problem, the easiest way to remember this: if it finds a problem, it pokes the B cells and says, "Hey, you need to create an antibody for this intruder that we found." So however you write that down, that's the easiest way to remember this. So again, the T cells are kind of the scout. They're out floating around looking for problems. When they find a problem, they give the nod to the B cells to start making antibodies to try to fight this, whatever this thing is that the T cells found. And that's pretty much how those two interact with each other. And that'll be important here in just a few minutes. So the book talks about the T cells. They start talking about how that's the biggest job of the T cells is to destroy antigens. An antigen is just a fancy way of saying germ or bacteria or intruder or whatever you want to call it. So again, that's what it says as far as the T cells are concerned. B cells. The book talks about that as some of the main functions include eliminating bacteria, neutralizing bacterial toxins, preventing viral reinfection, and producing an immediate inflammatory response. So this is what's going to be really, really important for us to understand is once the T cells tell the B cells that there's a problem, the B cells go out there and they start to search and destroy. As all of this system happens, there's these mast cells that sit on the surface of the skin. It's just below the surface of the skin that they're literally just standing by watching all this happen. All they know how to do, the only thing they know how to do is trigger this inflammation response, this inflammatory response. Because if there's this bad thing floating around, then we want more of this. We want more B cells. We want more of these T cells. We want more of these lymphocytes and these white blood cells. We want to increase our army size. So these mast cells, all they do is sit and just create just havoc at a surface level. That havoc by visual for us, that havoc looks like inflammation. So that inflammation is one of the big things that we have to try to fight to try to intervene in some of these shock symptoms. And again, this might be a little confusing right now, but as we move forward, it's going to kind of tie back together. So here's the definitions I was looking at. This is in a book. It is what it is. These and these PowerPoints, if you want to go back through them, these PowerPoints are going to live. They already live in the course folders, in the chapter folders. Something else I'm going to try to do, since just because I mentioned it, I know it's a little off topic. I'm going to try to take these recordings and I'm going to try to put them back in the chapter folders also, because there was this thing that we talked about or whatever. It'll be easy for you guys to be able to go back in there and try to fast forward and find that.
Real quick, Adam, do we need to memorize all these?
These, no. The ones I want you to know is the mast cells, the ones you wrote on the paper, the mast cells, the B cells, and the T cells. And there's going to be some versions of this, but again, this is not something that you guys are truly going to need. But what you need to know is that the body creates its own immune system, fights off a problem, and it manifests itself to us as swelling and inflammation. So let me repeat that, because that's really, if you don't take anything away from this at all, take this away. Your body finds a problem. Its process of ridding the body of that problem shows up to us as inflammation. And that's really what you got to know. So when you're sick, when you have an allergic reaction, when you have anaphylaxis, when you have any of that stuff, the problem that we're fighting is inflammation. We're fighting cellular inflammation. We're fighting a battle that's basically the body eating itself. And that's the sad reality of what the immune system does. So the COVID stuff, they're trialing this medication that's typically used for other autoimmune disorders. That's what the president keeps talking about. So this particular medication, really what it does is it kills your immune system completely. So if it kills your immune system completely and takes you completely out of this immuno response, then COVID, all of the indicators, all the problems that COVID creates, it creates inflammation in the lung tissue. It creates inflammation distally, like in most of the capillary beds in the tissue. It's creating a lot of those problems. But if we can give a medication that basically suppresses your immune system completely, all of this stuff that you're looking at on the screen, all of this stuff goes away. And if all of this stuff goes away, the body doesn't have a response anymore. There is no inflammation. So it's not that it's curing the problem, but and I should mention that viral medications in general, whether it's HIV medications, whether it's there's a whole host of autoimmune and viral thing, like for the flu. Yeah, we hear about Tamiflu. Tamiflu is one of the most dangerous medications that anybody will ever get. Tamiflu, if you've ever had it, you're probably in the lucky bunch. But Tamiflu is a very, very devastating med, because that medication literally gets rid of your immune system in a lot of ways. It suppresses and blocks it. And it makes you feel better because, again, when you have a fever, it's your body fighting something off. So if I can give you a medication to tell your body to stop fighting, this thing just runs crazy until it dies. And if it runs crazy until it dies in the body, you're either going to die or you're not going to feel any of the process of it, because, again, your body's not fighting anymore. So people feel better, which is why it's such a popular medication, because I feel good. I'll take my chances. So the whatever it is, the flu strain will run rampant in the body until it finally self-mutilates, or the body finally fights it off with whatever little reserves it has left. But at the end of the day, this Tamiflu and this other medication that they're given right now for COVID, that's really all it's doing, is it's suppressing the B and the T cells, and it's preventing those mast cells from getting aggravated. So again, this is just a fancy way of explaining that. So if you don't understand that, please write it down. Talk to me. We got to get that figured out. We got to understand that that the body, while fighting off a problem, fighting off an infection, fighting off an antigen, will show up to us as some type of swelling. And this is just the fancy way of saying why. So the immune system, there's two different types. I naturally produce a basic immune system. It's basically these T cells that are floating around. They're hunting out problems that they're aware of. The problem is all of these cells are learned cells. They all have to be taught. They don't just know automatically that there's a problem. So you have to be exposed to it first for the body to say, "Oh, I remember that, and I didn't like it." So an allergic reaction, you can have an allergic reaction the first time. If you're allergic to bananas, The first time you eat a banana as a kid, you might not have any kind of reaction whatsoever. But once you eat that banana and the body says, hey, there's this thing and I don't like this thing, then the next time you eat it, it says, hey, I remember I didn't like this thing. And that's when it starts to trigger this whole cascade of train wreck, this whole allergic reaction response. So natural immunity is my body's basically saying, yeah, I've seen you before. You're good. You pass the checkpoint. You can go about your way with no reaction. And acquired immunity is the flu shot. So basically, I have given you a protein strand in your arm every year in October or whenever it is. I give you a small little protein that looks just like the flu. In fact, it might be the flu. It might be a dead version of the flu. It's something that looks like the flu. So once that goes in there, the T cells say, hey, I'm not a fan of this. And it gets with those B cells, because remember, the T cells notify the B cells that there's a problem. Those B cells create the antibody. So from those B cells, they say, hey, this is flu. I don't like it, but we can take care of this. We can fight it. So all of our vaccines that we get, that is the exact process that they go through. We give a small injection of some dormant version of that or of that disease or of that illness. The body creates antibodies to it. That way, when it sees it again, it can bind to it and those white cells can kill it. Hopefully that makes sense to everybody. If it doesn't, please say something. So natural immunity is what I already have. Acquired is something that I get along the way. This is what I just said. The primary response is the first time we say, yeah, you might get some mild reaction, and this usually happens at the toddler age when they start exploring with other foods. There's a mild reaction, and then every subsequent exposure that you have to that allergen or to that antigen is worse and worse and worse and worse and worse. So a lot of times they'll tell you if you get flu, if you get flu once, the second time might be a little bit worse and a little bit worse and a little bit worse. There's some truth to that because, again, the body knows that it doesn't like it. So the next time you get exposed to it, and the next time those T cells find that antigen floating around the body, the response to fight it is going to be a little bit greater because it didn't like what it did to you last time. So that response, again, triggers those mast cells to start the inflammation process. And that's the scary part. That's specifically the scary part for allergic reactions. This is why anaphylaxis happens, because the body has had a repeat exposure to something that it doesn't like, and it needs to start fighting that off. And that's exactly what this the second, third, fourth, fifth, all of those subsequent exposures is why anaphylaxis is such a problem for us. Oops. So this is kind of an overcomplicated picture, like this book tends to do on a regular basis. But at the top, antigen, antibody. So again, antigen is the thing from the outside. Antibody is the thing that the B cells created to fight this antigen. These go together, they form this complex. And basically this complex, if you erase all the stuff below it, this complex floats around the body until a white cell can bind to it. And when the white cell binds to it, it destroys it. So you've destroyed one of your antibodies and you've destroyed that antigen. And then you rinse and repeat for every antigen that's found in the bloodstream. Very, very to the very surface, that is the simple way of thinking about this. I'm going to skip this because I don't like them. And I don't think we need them. And that's more confusing than it needs to be. Moving on. Did you guys get all that? Good. Cell-mediated immune, I'm going to skip that too, because I'm not a fan of that either. All right. So T cells, we talked, and again, I'm hitting on this just as deep as I think I need to, just to make sure that we understand what their functions are. Because again, the T cell, the B cell, the mast cell, those are the three, and then IgE. These are the things that we have to kind of focus on. So T cells, we know that these particular T cells and the B cells are almost interchangeable in a lot of ways. When you read about these, it's going to be kind of confusing. I don't like the way they go through this. There are different versions of these T cells, and this is kind of some of the propeller head things that have to do with the T cells. Again, I'm not super worried about you guys memorizing this. What I am worried about is this second to last one here. One of the main things that these T cells do is that they remember the reaction that the body had. They gauge the next exposure to that. So this is that allergic reaction again. So it remembers that it didn't go well the first time. So it's going to increase and ramp up its production of stuff to try to fix it more, basically more appropriately the second time around. And what it doesn't understand is that the more it tries to, quote, fix it, the worse we end up actually being, because again, that swelling starts to overcome the body. Swelling in lung tissue prevents trouble breathing, and just the whole cascade of shock, back to that distributive shock that we talked about before. So again, I'm not so worried about all these specifics, just the T cells, they're looking for the problem, and they remember the reaction the body had. So the inflammatory system, this is that response. So this is triggered because of the T cells. This is triggered because there's this antigen floating around the body. So we know that there's a picture coming up. There's a picture coming up that kind of goes over this a little bit better. But basically, this inflammatory response, we're shunting fluid to the tissue. We're shunting fluid to the capillary beds. Well, the capillary beds can only hold so much. And when they start to overflow, they start to, that you get that swelling, and that swelling is painful because that's not normal. So when you have all that extra blood flow at the surface, you have pain, you have swelling because there's more blood there. It's red because, again, you have blood floating there, and heat. We have heat because a majority of your core heat in your blood is now on your surface level. So again, this is why fevers feel hot. This is why your forehead feels hot, because you have all the extra blood flow to the tissue sites, or to the capillary sites. And I guess I should note the injury. We're not necessarily talking about injuries today, but injuries, it does the same thing. There's a really good picture a little bit later on about a finger laceration, where the body does pretty much the same thing, but it's to try to start to heal, or the healing process for that particular injury site. So we'll talk about that here in a sec. So acute inflammation. This is the rapid. This is the right now. Everything's starting to swell. This is anaphylaxis. Right now, at the drop of a hat, everything in the body starts to inflame. The blood vessels start to expand. As that all starts to happen, there's not a whole lot of blood left over in the pump to be circulating to the organs. This is where the MODS thing starts to happen. Once all this inflammation starts to go out to the skin, blood flow starts to go to the skin, your body is kind of in that hypovolemic state. You're not being oxygenated very well, because all the blood and all the tissue, all the hemoglobin, all the oxygen just went to the surface, and it's not floating around inside where it's needed in the core. So the big thing to remember with inflammation is vasodilation. That's how it happens. So that inflammation it's trying to get as much blood flow as it physically can. So it's gonna start to dilate everything. So it dilates everything to promote more blood flow. Again, the body's kind of dumb though. The body doesn't realize that if I open up those vessels, if I open up and get a bigger hose line, you're not going to have as much volume, or I'm sorry, as much pressure. You're not going to have that. So now you're starting to have the gravity issue where if everything starts to dilate, your core is not perfused. So this all goes back to why we elevate the feet in these shock patients, because again, this inflammation, to do that, you have to dilate everything, or the body's dilating everything. We'll go for a couple more minutes real quick, and then we'll take a little brain break here. We talked about this. As far as the cells are concerned, platelets are what carry everything around. We know that's the fluid part of the, I'm sorry, that's not the fluid part, that's plasma. Platelets are what carry all the proteins to start the building process to fix an injury. So this is like where clotting and stuff happens. So that's more of a trauma level. But the white blood cells, that's your lymphocytes. That's the stuff that's going to start killing, stuff. The platelets are going to start repairing damages and they're going to form clots. Mast cells, we know that those are the cells that create the inflammation at the surface. That's the problem. That's a problem with those. And by the way, for your paper, IgE cells are the triggered allergen cells. So those cells will activate the mast cells for allergies. And we'll talk a little bit more about that in just a minute. But that's going to be important to the allergic reaction response. But again, if your head's spinning, your body fights stuff off by shunning blood flow to it. That's what you got to know. That's really what you got to know here. So mast cells, they're going to degranulate and release kind of toxins. I guess it's without getting deep into that. But again, mast cells, their whole job is to sit under the surface of the skin and allow swelling to happen. That is what mast cells are. That's all you got to know about those. And with the protein stuff, let's take our break now, because this is I'm going to hit on some of this stuff and skip over the rest. So we'll take a little break. If you can give me, I don't know, 10 minutes, something like that, I'll be right back with you. All right. So bringing it back to it, plasma protein, it does a whole bunch of other stuff. The one focus, and if Alex brought a good point up, if you guys read the chapter and you have a basic fundamental understanding of some of the stuff that I've skipped here, you're probably ahead of where you need to be. And that's definitely a good thing, because it does create that foundation that we're going to go back to time and time again as we move forward. So I am skipping some of the more complex stuff. A lot of the stuff that you would learn in med school that I promise you guys by the end of this class, you will forget, which means you probably won't need it super often in the field. But if you're like me, there is a period where you do kind of you want to understand the why part of what we do, and this is kind of what that is. This is understanding why things happen the way they do, why the body responds and reacts the way it does. But if you don't, and you're more of a nuts and bolts, just trying to put it all together, so you know how I'm going to be able to use this in the field, that's pretty much what I present based on. And then I throw in there what you guys need for testing. All right, so we left off finishing up the mast cells and the inflammatory response system. So the plasma protein system, the only part of this that I'm really super concerned about is that we understand the coagulation system. So this is back to the inflammation, that instead of the word antigen, we're now using some kind of traumatic response. So a laceration, or whatever it is. So coagulation system is what basically stops the bleeding. Definition purposes, it forms clots in the blood vessels. It forms clots by way of these fibrin systems. This whole fibrinolysis cascade, this whole system here is it's basically. So the body does a couple weird things. It tries. So if I have a laceration in the finger, or let's say it's a little bit deeper than that. There's some type of venous bleeding, significant venous bleeding. What ends up happening is the body's going to initially try to form this clot. The clot's going to stop the bleeding. It does that basically by removing plasma from the blood. So if I can dry out an injury site, then I've essentially stopped the bleeding thereafter. At a certain point, the body also knows that it doesn't want these fibrous pieces of protein floating around the body in the bloodstream, because, well, that's where strokes come from. So at the same time, at the end of the system, or the end of the cascade, or the end of the cycle, the body tries to break down those clots, so to prevent that from moving through. So as healing starts, it goes back and it tries to dissolve that fibrin tissue that it created originally to stop the bleeding. So you guys have heard of the tranexamic acid, or TXA, that we carry. TXA we give for trauma patients that are bleeding. That's one of the hardest medications to understand. But basically, what that does is it inhibits this fibrin cascade system. It inhibits the body from breaking down the clot, because we want it there. So if you've got a patient that's bleeding some kind of significant arterial bleed or whatever it is, and you've got pressure on it, you've got a tourniquet on it, you're trying really, really hard to get that bleeding to stop. The last thing you want is this cascade to intervene and start breaking down that clot that it finally made to stop that bleeding. So TXA inhibits the body from breaking down its own clot, and this is the cascade that it directly affects. So that's kind of important for us to kind of understand. I'm going to skip through that, but I'm going to skip through that also. All right, so here's that picture I was talking about, and this is if you have a textbook. If you don't, I still have a couple that are still unclaimed that I'll get with you guys. But page 449 has this picture in it. So basically, this is actually, it looks like a lot, but this is actually a really, really good picture to kind of put together what we just talked about. So there's a cut finger here. On one side of the house, these white blood cells are going to try to fight any infection that might come as a result of this laceration. So maybe something got into the capillary bed, and if it got into the capillary bed, it has the ability to get into the bloodstream. So we're going to try to, the white cells are going to try to do their part to make sure that that doesn't necessarily happen. So it's going to go through and it's going to create this layer of basically protein. It's pus, what we would all think of as pus. But basically all it's doing is creating a membrane between the capillary bed and the skin to try to make it so that nothing else can get in. No germs, nothing bad can get in. No bacteria, no virus, no nothing. So that's what that's what happens on one side of the house. On the other side of the house, the body has to start this healing process. And to get to healing, this is all the different stuff that the body has to go through to be able to do that. So first and foremost, it releases histamine, which basically, again, we're going back to the swelling system and the mast cell system. So all of that activates. And as that stuff activates, we have the dilation of the blood vessels to allow the blood flow to get to the skin, because inside the blood flow, inside the blood, again, we know is those lymphocytes, and we know that the white cells want to get there, and we know that the clotting factors and everything else want to get there. So it dilates the blood vessels. As that happens, you end up with the redness at the skin, because again, you've got a collection of extra blood in the tissue now, and because of that, you have redness and heat. When you have redness and heat, you have an increased temperature, and you also have pain, and you also have swelling, because again, you have more fluid in this space than your body's used to normally having. So as this plasma leaks into this tissue, as this plasma, blood, whatever you want to call it, as this leaks into the system, you end up with this pain and this swelling. But in addition, you're also getting the oxygen and nutrients that you need for the healing process. You also have the clotting factors, which we'll talk a little bit about clotting factors. The book talks, there's a big chart in the book about the different clotting factors, but basically all a clotting factor is again, it's your body's ability to form a clot. So once that clot happens, you end up with this little hard scabby thing, which is exactly that's what it is. It's the clot. Then the body goes through this healing process where it starts to break down that clot at the end. So this is kind of the full picture of what an insult looks like. So prior to today, you knew that your finger, when you cut your finger bleeds, you hold pressure on it, it stops the bleeding, and then it starts to heal kind of from the inside out. Like that, that's what the general average person thinks about a laceration. All of this stuff on the inside here is some of the other technical jargon that goes into it. But again, the important reasons for us to know this is why our patients, why injury sites become hot, why they become swollen, why they become red and discolored. That's pretty much what this is talking about here. So I'm going to skip through some stuff. So here's the process of the actual healing, and we talked kind of about it. So it's going to try to repair the tissue, and that usually happens from the inside out. And that's there's a lot of protein stuff that goes on inside the tissue to try to regenerate tissue and try to regrow that tissue. It needs to start removing that inflammation. So again, when you have more blood flow and more oxygen to a site, then you have more byproduct that comes out of that, because the body's going to try to use that oxygen. It's going to try to use that stuff that came off the hemoglobin. So you're going to have all this extra debris and all this extra stuff. It's going to start to restore the tissue, and then you're going to start to build the new tissue. And that's pretty much the end of that. I'm skipping through. So dysfunctional healing, this is a term, this is specifically related to people that have some type of factor disorder or clotting factor issue. That's something that it's not super important necessarily to understand today. But it is important to know that some people have the inability, they're unable to create a clot in the body. Some people have a problem where they create too much of a clot in the body, and that's equally as problematic, because again, you've got all this extra protein, fibrin tissue that's floating around inside the cells, and we don't necessarily want that either. So knowing that just know that some people have the ability to clot, some people don't. Some people take Coumadin, and I know Coumadin and warfarin, both of those are basically, it's a blood thinner is what we call it. Well, really what Coumadin and what warfarin, what they really do is exactly, it's this. They prevent the body from being able to clot. They take away some of the clotting factor. So when you hear about the patients that are on Coumadin or on warfarin, and we know that it's a blood thinner, and we know that when they fall, they're going to bleed and they're going to continue to bleed, Well, this is why, because they don't have the ability to create that fibrin to make a clot. So that's important for us. What's more important for us is to identify those patients, specifically the elderly patients that are on Coumadin that fell and potentially hit their head. Those are some of the most critical patients that we usually overlook, because, you know, again, those patients, they've got some kind of bleeding in the head that cannot be stopped. And at the end of the day, that's super, super dangerous. So depending on where you work, a lot of the hospitals locally here, if you have a head injury that's elderly, that's on Coumadin, they usually go to a trauma room. They usually go to a trauma bay. You may or may not have seen that. But they take that very, very seriously, because again, the body doesn't have that ability to create that clot. So some of the chronic inflammatory systems, this is not something that I really want to go too deep into, but some people do have either an overabundance of mast cell responses, or they have some type of ongoing infection or something like that. That's not something that can be fought normally or by traditional means. So this, I wouldn't worry too much about this at all. I can't even think of a disease process that we would commonly see that would have something like this. Sorry, too many. So here are some of the variances in kind of what we talked about. So hypersensitivity, this by and large, when you get called to the allergic reaction, a hypersensitivity is one of the more common allergic reactions that we hear. So people say, you know, I can't have morphine. Well, why can't you have morphine? Well, because I'm allergic to it. Well, what happens when you take morphine? Oh, well, my face itches a little bit. Okay, cool. Or my favorite is, why can't you take fentanyl? Well, because it makes me sleepy. Well, yeah, that's not an allergy. If it makes you really sleepy, and you know, low doses affect you greater than what the normal person would, then maybe you do have a hypersensitivity, where maybe your body does metabolize that differently. So hypersensitivity is really just a term that just says your body overreacts to whatever the problem it finds. And that can happen in an allergic reaction process, or that can happen at a cellular level with injury patterns. And that's really, as far as is concerned, allergy is really where this is gonna show to us more often than not. So this is the process of inflammation. I'm not so worried about the type as much as you guys understanding that some of these processes can happen right now, and some of them take a little bit longer to happen. So this type 1 is an immediate hypersensitive reaction. So this is a reaction that happened right now. So a bee stung me, and right now I'm dying. That's pretty much what this is. So again, knowing what we know now, the bee stings me. Those T cells say, "Oh, I don't like this at all. This is no good." It nods to those B cells to create the antibodies. Those antibodies go out there and they start binding to all of this, to all the antigens that were just put in the body from this bee sting. As that happens, those IgE cells and those mast cells, they start to fire off, and they start the inflammation process, because again, we want to get blood flow to that site of the bee sting, which ends up creating this full, it's almost a global reaction or a global response to this bee sting. So now all of my blood vessels are dilated, my heart rate goes up, my blood pressure tries to go up, but again, you're fighting against a really, really big dilated blood vascular system. So you're not really pumping at a higher pressure. In fact, you're probably pumping at a lower pressure, because again, you've got these massively swollen vessels to try to shunt blood flow. So this whole reaction happens almost instantaneously. So we're getting into the anaphylaxis. So give me a definition of anaphylaxis, whoever. Cody.
I just say your body is overreacting to a certain antigen or substance. So basically hypersensitivity reactions, what I would call it.
Okay. So if you ever see a test question for anaphylaxis, basically anaphylaxis is a process that involves, it's an allergic reaction response that involves 2 or more body systems. That's probably worth writing down, highlighting, circling, writing in Sharpie on your hand. That's one of the most important things as it relates to anaphylaxis. So anaphylaxis is an allergic reaction that shows up in 2 or more body systems. So what exactly does that mean? So this antigen gets in there, the body starts doing its thing. Those T cells, the B cells, now these mast cells are starting to create this swelling. So I have swelling redness at the skin. That can look like hives. That can look like some type of mottling. So that is a skin reaction. The skin, the integumentary system, that's one body system. So just having a rash and swelling because of an allergic reaction, that's one body system. If that patient's having a hard time breathing because all of that inflammation that the mast cells are creating creates a problem in the lungs, where now you have this swelling in the lungs, which creates wheezing. Now you have two body systems. So you have wheezing, you have a skin reaction. That's two body systems. By definition, that is anaphylaxis. You can go a few steps further and say, well, maybe to compensate for this, you have this global vasodilation. You've got this increased blood flow, but because of the dilation, your blood pressure is in the toilet. So now you might have a cardiac thing because you're tachycardic and you're hypotensive. There's a fourth body system. And then maybe another big body system that's tied to an inflammatory response from an allergy is the GI system. So maybe these patients have diarrhea, or maybe these patients have significant stomach cramps. There's 5. We have several. These are just some of the thought processes. So you've got somebody that's outside cutting grass and all of a sudden has shortness of breath, hives, and abdominal pain. There's 3 body systems right there. This is an anaphylactic patient. That's what that is. So we know that this anaphylaxis process started because of the swelling, because of this inflammation process. That's where anaphylaxis has really came from. That is why epinephrine, we give epi, and we'll get deeper into epi later. But epi, its number one action is vasoconstriction. It'll tighten everything back down. So we know that if we can tighten everything back down, that prevents that excess of blood flow to the surface, to the skin. It keeps all the vital organs perfused because it's not letting blood flow go elsewhere. So epi is pretty much the one most appropriate treatment for an anaphylactic patient because it happens right now. We give them the shot, it gets in the body, it stimulates better breathing, and it stimulates better vascular compliance. So those two things offset this allergic reaction. But now that we're thinking at a higher level, epi wears off. So epi itself doesn't kill the antigen. It doesn't kill the bee sting. It doesn't get rid of that. All it does is tells the body to stop swelling, and it fixes the blood flow. So once that wears off, there is a possibility that they go right back into anaphylaxis. And that's when they get another shot of epi. And we're going to continue that until the body finally creates enough antibodies to bind to that and have the white cells excreted from the system. That's deep. Please ask questions. If this doesn't make sense and I got to repeat it, please tell me now.
Can you explain what IgE is exactly again?
Yeah, let me go back. I'll go back and I'll read you. That's actually a good question. I think I don't know if I passed it. I think it's coming up still.
Like when we're talking about like a bee sting with natural immunity, someone's like super allergic to it, we are not talking about like T cell activation at all because it's IgE, not T cells, right?
That is correct. Somewhere, and I don't know where it went. I just lost it. There's a really, really good book definition of IgE. All right, so IgE, and then I'll read the book definition and I'll put it in terms we kind of get. The most common blah, 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 blah. IgE accounts for 75% of the antibodies, and if you're in the book, it's on page 445. It's in the table. It accounts for 75% of the antibodies in the blood. It is the only immunoglobulin that crosses the placenta given. Okay, so I lied. That's really a very, very crappy definition now that I think about it. So the biggest thing with the IgE cells, those IgE cells, and before I give my definition, does anybody have their own definition for IgE yet? Just after reading the book? Nobody? Anybody got anything?
Antibody that's usually linked to allergies.
It is. It is essentially the search and destroy for allergies. That is so T cells in general and B cells in general, those are looking for virus and bacteria. They look for other things, but they're looking for viruses and they're looking for bacteria. Once it does that, it's going to go off. And again, so backing up a little bit. So T cells, they find that virus, they find that antigen. They stimulate the B cells to produce antibodies. The antibodies bind to that antigen, and the white blood cells kill it. That is the physical intruder that it deals with. IgE is a common thing that's floating around the body. So you have something that's relatively normal. It's not a virus. It's not categorized by the T cells as being an intruder in any way, shape, or form. That it is looking for that one specific thing that's in the body's memory. So again, remember the T cells remember things. The T cells remember the response. The T cells, they will remember very specifically that we don't like the bee sting. We don't know what to do with the bee sting. We have no way of creating an antibody for the bee sting. So the IgE cells are what finds those things. That's what finds those antigens that the body can't otherwise identify as either a bacteria or a virus. And then the IgE stimulates the mast cells to have that inflammatory response. Does that sort of make sense? So IgE is the allergic reaction side of what T and B cells do. Does that kind of make sense? Savannah?
Yeah.
Okay, cool. Honestly, again, I don't want to. Don't get too hung up on some of these cells. Again, the big take home today is that the body, while fighting, will create inflammation that we have to intervene in. That's what today's take home is truly going to be. So now we're moving down from the first the type 1 that we're talking about. And again, I'm not so stuck on the type 1, 2, 3, but I'm more concerned with the acuity. So type 1 is right now. It happened right now in real time, and they're dying right in front of you. They're going to die right in front of you if you don't intervene. And the only intervention that we have that's going to prevent them from dying is to allow the body to go back to its normal oxygenation state. So we have to give that epi for them to be able to vasoconstrict and get blood flow effectively through the body. So type 2 is this hypersensitivity where basically these IgE cells, they go out, they're looking for antibodies because, again, it's not a virus, it's not a bacteria, it doesn't really fall in the other category, but they're trying really, really hard to rid the body of this particular allergen. This can show up in a couple different ways, but it can show up as maybe one body system if you need like a hard specific number. Remember, anaphylaxis is 2 or more body systems. So this is specifically the body's response to that, knowing that it's, it identifies it, it knows what it is, it knows it can deal with it, kind of slow but sure. A lot of times this is like the transfusion reactions. This can be like post organ transplant where like, this isn't my blood, I don't know what it is, but I'm okay with it, but I'm not super happy about it. And this can manifest as a little bit of like site swelling. If in the case of a transfusion, just generally they just don't feel well. They feel kind of like they've got a fever. They just feel generally unwell, and that's kind of what this is. But again, this is like the autoimmune people, the blood transfusion, the organ donation, or organ recipient, and stuff like that. The type 3. This is a little bit different as we start to kind of scale back to these more chronic patients. These are people that live with these problems their whole life. Again, the lupus, the HIV, things like that. These are the body. The body knows what it is. The body just can't physically fight it. Just doesn't really have the ability to. So a lot of times these particular patients are on those immunosuppressant medications that we were talking about. Because again, if we can drop the immune system or scale back the immune system's response, then we scale back that swelling and that tissue inflammation. So that's kind of the treatment path for these people. But again, lupus and all the other autoimmune type diseases kind of go into this. And then this one is like the super long term, and this is not something that we're probably going to deal too much with. If you notice at the bottom, there's delayed hypersensitivity, which is basically the body's like, yeah, this sucks, whatever. They're kind of it's kind of letting it just kind of slide by. There's not really a whole lot of reaction to these people. They literally, the body knows what it is. The body knows that it can't fight anything to do with it. And again, I don't want to spend too much time on this because these are not our acute patients. Rheumatoid arthritis was listed in here as one of the hypersensitivities. Rheumatoid arthritis and arthritis in general, just the swelling and inflammation inside the joints. This is something that people that have it, they're in excruciating pain 80% of their life. So that's, this is that weird autoimmune. They don't really have the ability to create an antigen or an antibody to fight it. So these are patients you feel sorry for, but really all they can do is, they can put them on those immunosuppressant medications. These are some more. We're going to talk about this stuff later. I don't want to go into that stuff today. Immunodeficiency. Immunodeficiency. Okay, so shifting gears. People are immunocompromised. We know that. We know that cancer patients are immunocompromised. We know that before masks were cool, there were kids that wore masks. There were people that wore masks, specifically when they were undergoing chemotherapy and radiation. Again, chemotherapy. That's another thing. Now that we're thinking like medics, chemotherapy really that goes in there and it kills the blood. It kills your. It starts to kill your body's reaction system. So if it starts to kill the body's reaction system, then it doesn't poorly react to whatever the doctors are trying to work on and fight. So again, it's not without consequence. Because now if they're immunocompromised, if they don't have the T cells, if they don't have the white blood cells or the lymphocytes, if those aren't floating around the body, then the general cold that the body otherwise would say, hey, I know you, I know how to fix you. It doesn't have the troops or the soldiers to go out there and get it because they're all killed off because of the chemo. So that's why these patients are immunocompromised. They usually they wear masks, they stay home, they stay out of public. They try to limit their exposure because again, they don't necessarily have, they don't have the stores of antibodies to be able to take care of their, whatever the problem may be. So some of these, they're talking about some of the acquired ones. Really, I'm not even super concerned about the acquired ones. But basically, here's some of the reasons you might develop it. And again, I'm not super worried about that. We talked about some of the treatment. Ultimately, we can do the bone marrow transplant. If you do a bone marrow transplant, then you gain the T and the B cells. You gain more if the body's not producing enough. If you're changing, and that pretty much is the same with the transfusions. If you do a blood transfusion, you're going to get white cells to a small extent, but this gets super complicated also. So again, immunocompromised people, we know why they have it. They usually know why they have it. It's some type of either medication or it's some kind of disease process that's hampering them from being able to fight off any kind of disease or infection. So, anybody have any questions on that? I am hopeful that a lot of the cellular stuff is somewhat behind us now. So that's probably good news. It's probably good news. All right, so diseases. This is going to kind of round out the patho chapter, and then we'll be able to kind of shift gears from here. So there's a whole plethora of things that affect your body's response to this disease. Again, we know that at the core of the disease, it gets in the body. The body is going to try to fight it. Some people are more susceptible to getting some hypersensitive response than others, and these are kind of some of the factors. So the uncontrollable ones, genetics. If mom has diabetes or grandma has diabetes, you are at an increased risk of having diabetes. It's genetic. It's just the way it is. Race is another one. If you're African American, you have a higher chance, almost at 100%, of having sickle cell over a Caucasian person. So that's uncontrollable. You have no ability to fix that. Controllable. A lot of times in the medical world, we substitute controllable for environmental. So these are environmental things. So if their home environment or their personal lives or their personal environment includes any of this stuff, then obviously they're going to be at an increased risk of having some types of diseases. So specifically, when you look at smoking, we know what smoking does. Smoking damages the alveoli, and if it damages alveoli, then we know that they're going to be susceptible to lung diseases because the lungs just aren't functioning appropriately. Alcohol and so on, they have their own inherent risks, and those are obviously controllable factors for how your body responds to a disease. Newborns, we know that newborns, they don't have an immune system that's fully matured yet. It doesn't know a good antigen from a bad antigen. Remember, those T cells are those little TSA cells, the little T cells that are floating around looking for stuff. It doesn't know what it's looking for. Those operate off of a learned function. They have to understand it. They have to see it before. If a T cell's seen something before, then it can react appropriately the next time. Newborns don't have that. That puts them at risk. Teenagers, somewhat the same. And then older adults, on the flip side, their system, by the time they're elderly, their system, either they don't have the immune system that they used to because they don't have the same number of white cells. They don't necessarily have the same rapid production of the T cells and those B cells. It doesn't have, everything is slowed in old people. So including this. The other thing with old people is a term we like to use is comorbid. They're usually, they've got a whole life of other problems. So again, it could be smoking. It could be that they're on Coumadin, or they could be on some other type of immunosuppressant medication. So we know that they're at risk or at a higher risk. When it comes to sex-associated factors, obviously I'd have a hard time getting some type of uterine disease. So that is what it is.
Hey, Adam.
Sir.
Is it still believed that the breast milk does the newborn antibodies for 6 months, or is that kind of scientifically been fizzled out?
No, it does. It does, and there's some back and forth on that. The big thing with when you say antibodies, this goes back to that IgE cell. So IgE is basically that search and destroy cell for like allergic responses that can cross the blood-brain barrier through breast milk. So basically, mom's IgE cells can absolutely pass through to the child. So the problem with that is those cells, again, they're adaptive. So that let's use a milk allergy, for example. So a kid, a newborn, the first time they're exposed to this milk allergy, they're not going to have any kind of systemic reaction. They're not going to have that inflammatory response. So the first time is not a big deal. The second time might not even be a big deal. But by the third, fourth, or fifth, those IgE cells that are coming from mom into the baby, there's going to be a reaction that says, hey, we've seen this a lot. We know what this is. We don't like it. And they end up with this allergic response. And that allergic response is what triggers the mast cells and the inflammation, and down the cascade it goes. So yes, a lot of that does come from mom. What doesn't come from mom, and where some of the confusion is if mom's allergic to milk, her IgE cells will respond. But when a baby has the same IgE cells, those cells within the baby may not respond like the ones in mom do. So that's where a lot of the confusion comes in, because what ends up happening is those IgE cells say, hey, this is something we don't like. I don't want anything to do with this. And mom will show as a full anaphylactic reaction. Same IgE cell gets put into the newborn. The newborn's body says, yeah, I don't like this, but the white cells don't attack it. There is no response from the rest of the newborn's body other than this trigger cell that says, hey, I don't really like this. And it basically falls on deaf ears. None of the other system, the immune system, none of that functions from there. Does that kind of make sense? All right, cool. I'm going to skip through some of this. Here's some other the risk, and we will talk about this in length. Every single one of these on here, you guys will absolutely have to know thoroughly. These are my key phrase for the last couple of days is you probably won't need to know this. This stuff is not that. This stuff you will absolutely have to know. Today's not really the day to go too deep into it though. But emphysema, we know that breaks down the alveoli, which is the days that you start to get kind of overwhelmed and frustrated, if you start going back through some of these charts and you start looking at some of this stuff, it's going to start blowing your mind how much of this stuff you actually remember. A month ago, you might not have had any idea what alveoli are. You might not have had any idea how they actually reacted or what they were. You didn't know that they were these little air-filled sacs that are responsible for cellular respiration. Didn't know that. So there's little small goals that we're looking for here. And it's just this slow process of us just starting to build on basically what we're learning. So looking through this stuff, we know what it is, but now we kind of know a little bit more of how the body's reacting and kind of why. So like skipping down to asthma, we know that there's a constriction in the bronchioles. Prior to a month ago, you might not remember what the hell bronchioles even are. And why does an asthma person wheeze? Well, they wheeze because there's an allergen in there. And when there's an allergen in there, the IgE cells stimulate the mast cells to produce inflammation. So you learned that today. You might not remember it as soon as we end this meeting today, but you've heard it before. So when you hear it again, it's going to sink in. And then knowing that these asthma patients, we need to do a couple things. We need to try to get rid of that swelling, which, by the way, a bad asthma attack, we can give them epi. Because again, epi does that. Epi constricts the blood flow. And if it constricts the blood flow, then there's not going to be the inflammation in the lungs anymore. We also give like albuterol, and we'll find out that albuterol it stimulates breathing, and it opens up the bronchial system. So why things interact with the body the way they do is kind of what we're after here. Familial diseases. This is these recessive traits. These are the things that get passed down. And again, there is some talk that if mom and dad are both, if they have high cholesterol, there's a possibility that can be passed down. If mom or dad have some strange factor, clotting factor disorder, that stuff can be passed down. If there's a hyper or hypoactive immune system, that kind of stuff can be passed down. We don't necessarily know why it all goes back to the DNA. It's just in the DNA, and that's passed on from generation to generation. Asthma is one that we know is something it's in the family. Something else that I didn't know until the last couple of years is the aortic aneurysms. If there's anybody in your family that in your family tree that's had an aortic aneurysm, you are at an exponentially higher rate to have one yourself, which is interesting because really what an aortic aneurysm is it's a thinning in the lining of the aorta that allows a bubble to pop out. And when that bubble pops out, at some point it pops. And when it pops, well, you're in trouble because that's the aorta. So knowing that kind of stuff and knowing a family history is absolutely important to us. So when you're doing your medical assessments, it might behoove you to ask them, do you have any history of asthma in your family? Do you have any history of aneurysms in your family? Do you have any history of cancer in your family? That's why family history is so important, because it truly can indicate a problem for us. Overcomplicated crap that I'm going to skip. All right, cancer. Cancer is terrifying. It's terrifying to me for a bunch of reasons, but it's definitely terrifying to our profession in general. Really, what is cancer? Well, it's a malignant growth that basically is a growth of cells. The cells duplicate, and as they duplicate, they create these tumors, depending on where they're at. If the cancer cells live in the blood, they're going to duplicate in the blood. If they live in the liver, they're going to duplicate on the liver. So wherever they're at, they're going to duplicate and wreak absolute havoc on whatever that system is until it's stopped. The stop for it as it grows, if it's on the pancreas and it grows, it can grow onto the stomach. It can grow onto the liver. It can grow onto anything else in that abdominal cavity. So as it starts to grow, it's just going to keep growing until something stops it. Unfortunately, we don't know how to stop it. We don't know how to stop those cells. There are some studies out there that we'll kind of discuss here in a second. Radiation, really what radiation is a very, very isolated laser that goes, it's easy to think about a laser that they go in there and they attack just the cells that are there. The problem is you're also attacking all the cells that surround it, healthy or not. So that's a very barbaric treatment. The radiation is. Chemotherapy is also a very barbaric treatment because again, you're killing stuff. You're killing body's reaction system to try to kill these cells. But again, you're killing these, but you're also killing the cells that we need. So as far as some of the different types, We can go on for forever on some of the different types and some of the different research that we have on these. Lung cancer, we know that we're at risk for that because we're breathing in essentially worse stuff than what cigarette smokers are breathing in if we're not careful. So we know lung cancer is a problem. Breast cancer, breast cancer is one of them things that, this is another familial disease where you just don't know. You don't necessarily know you have it if you don't check, and there's really no way to put yourself at a greater or a less risk in a lot of ways. Colorectal is kind of the same way. It kind of is what it is. A lot of it is familial. Shifting gears from cancer is diabetes. We talked about it being passed down from generation to generation. Every single term that looks confusing on here is absolutely a term that we are going to use. We are going to need. Diabetes mellitus is the technical term, or mellitus rather. It's essentially a chronic disorder of the metabolism. Now, it uses the word metabolism there, and I think that's kind of weird because we know diabetes, it's more glycogen and glucose, and those are the terms that we care more about. But at a cellular level, metabolism is what processes all of that stuff. So if the body is processing sugar or it's not, then this is a function of the metabolism rather than just glucose. So ketoacidosis is absolutely a term that we are going to use really, really frequently. And then non-ketoacidosis is a whole nother ball of wax. But so type 1, these are the type 1 and the type 2 diabetics. And type 1, again, we just know is they're insulin dependent as it relates to this. And then type 2 is that non-insulin dependent diabetic. You'll know that. You'll know that when you show up there. They'll know. And let's be honest. Do we care? Not necessarily. If their sugar is low, we fix that. If their sugar is high, we can't really fix that. But what we can do is we can get them to the hospital. We don't necessarily carry insulin. We don't carry anything to lower our blood sugar. But what you'll find as we move forward through medical stuff, we can dilute it a little bit. So I can give a whole bunch of fluid. So if there's a too high a concentration of sugar in the body, I can just give more fluid. So just give normal saline, and that will dilute the amount of sugar that's physically floating around the bloodstream. So some stuff that we can kind of do. It doesn't fix the problem. It just minimizes the symptoms. This goes back to hemophilia. This is all the clotting factor disorders that we talked about before, whether they don't have the ability to form clots or they don't have iron or whatever it is. I'm not too worried about that stuff. Cardiovascular disorders. These are terms also that you guys will be very, very familiar with. Long QT syndrome is basically a delay. It's a delay in the discharge of the heart. So it's without getting into cardiology, it's just it changes the conduction system, and it delays a part of the heart from beating. We'll get into this, but this is something that's passed down. Syncope. Syncope is a huge term that we're going to use on a regular basis. It's just somebody collapses and they lose consciousness momentarily for maybe an unknown reason. A lot of times this has to do with either standing up too quickly or hyperventilating. We know that if you blow off too much carbon dioxide, we know that can cause a momentary loss of consciousness and things like that. Cardiomyopathy, any type of heart disease, most of that stuff is hereditary. Mitral valve prolapse, again, Mr. Benny, what's another term for the mitral valve? Do you remember? Oh God, he left.
I do not remember.
Who's got it? Somebody?
Bicuspid valve.
So I heard all three. So tricuspid. So again, and this is worth remembering. So the mitral valve is the bicuspid valve. Bicuspid valve. And the bicuspid is by the bicept on the left side of the heart. I hate that they use these interchangeably, but they do. Mitral valve this is a very, very common cardiovascular disorder. And by disorder, I use that term loosely. My wife has it. You'll never know it. She never knows it. Occasionally she'll feel like palpitations, but it's a very, very common thing. They can do a surgery. There is a way for them to replace your mitral valve with a pig mitral valve from a pig, and that's been pretty effective. But again, we're doing a very, very invasive surgery for something that's usually not symptomatic at all. So just something to think about. So mitral valve is the bicuspid valve. The tricuspid valve on the right side of the heart does not have any other name. It is just the tricuspid valve. So coronary heart disease, basically what they're talking about here is an actual vessel problem. So if the vessels by nature are not ran in the right location, or if the vessels by nature are not pliable, like they can expand and contract if they need to, just that's all stuff that's out there that we'll talk about later. And then stroke, which again, stroke can lead to that occlusive shock that we were talking about, where it's preventing blood flow from getting somewhere important. I don't want to go too deep into this stuff. Kidney stones, gout, and that's really about it for that. Gastrointestinal problems, basically, yeah, this is all pretty normal stuff. For what it's worth, if you guys aren't by the camera, try to get by it. Mr. Travers wants to pop in and say hi, I think. And then we're just about done with this chapter anyway, so we should be good. Just to kind of round out the familial stuff, Huntington's disease, a lot of this stuff gets into some of the adrenal responses from the body. Multiple sclerosis is more of a muscle type issue, and a lot of this, again, is hereditary. And lastly, Alzheimer's, we're very familiar with that as far as a memory disorder, or, this is more of a late stage disease with elderly population. Mr. Travers, welcome. We're kind of at a point, if you have anything, any good words of advice or wisdom for us, or you just pop in and say, hey?
Hey, good morning to everybody. Hold on, let me just do my video so you know I'm really dressed. Actually, up early in the morning. So hey, thanks for being here today. As we move forward, I think about 8 minutes from now, you guys are all getting an email, and you're going to get a phone call to the phone record. It'll be a phone message. Anyway, it's from marketing, and it's about our plans to reopen in the next, they use May 4th as the date, but we have some logistical things that we need to take care of. One of the big things is during this pandemic, we were blessed to have a fair amount of PPE, and we openly and freely gave that away and donated it to agencies that needed it. So it creates a little bit of a problem now for us to open back up without any PPE. So I am cautiously optimistic that we'll get it back soon. Some of the things, we've got digital thermometers, things of that nature coming next week. We got some face pieces, not some, but face pieces and gloves and that kind of stuff. They say they took all our gloves. I don't think they knew actually where they were. So we'll just leave that between this session here. But so anyway, lots of logistics, lots of moving pieces, lots of things that we're trying to work through, what ifs and yeah buts, and what do you do with a student as an example if they're here and they don't have a mask, if that's a requirement. So we got attorneys involved, we've got the Board of Education, we've got the executive management team. So I've been spending, I know that some of us this work from I imagine that's probably not a full day, but it's really been a challenge to keep it to an 8-hour day. So in any event, I just want to assure you that in the next, you'll probably get something from me. I'm going to call it Ask the Director. I'm going to send out a Zoom meeting. You guys can ask me whatever you want. I'm just trying to get clarifications on some things that I think are going to be asked. So if you want to submit questions to me, so that'll be a forum that I want to entertain. And I just want you to understand that, we're doing everything we can. It's not like we're sitting around, and there's a lot of pushback from a lot of different agencies. Gosh, I mean, our superintendent was involved with the governor's superintendent's task force relative to closing schools for the rest of the year, and was there's a rumor flying around that this may be for K through 12 schools may be delivered next year, in the first part of the first semester of next school year. So we've been told to prepare, we meaning the district has been told to prepare for online learning from August through December. So it's a challenge. And I think in some cases, I think we're getting lessons delivered in a more efficient way. And in some cases, I think it's probably not as efficient as it could be. Not necessarily on the adult side at all. I'm just thinking of some of the challenges that some of our learners have with regard and respect to learning disabilities and things of that nature. So in any event, it's a challenging time for all of us. I know that you and gals are probably all affected by that. And I wish there was some magic pill that I could say that, you know, hey, we're all going to be back together. Everything's going to work out next week. We're all going to have a ticker tape parade like De Blasio in New York is, but it seems like that's going to happen in the near future. Rest assured, we will get you through. You will learn, and the opportunity that we can get back together is forthcoming. And I'll be sending something out soon. But I think to your emails and your phone, that message is supposed to go out according to marketing and our BT sources at 10 o'clock this morning. So a good point to segue in there. So it's going to go to your personal email of record, and then whatever phone call, or excuse me, whatever phone number that you provided us during registration. So that's gone out to all 244 students point. So or will be in, I guess, 3 minutes. The other thing I want to bring up, and I want to address all the classes. Again, I want to address this. Anybody that has any questions, the CARES Act is a pretty big Federal Register document, several thousand pages. Actually, it's about 900. But one of the things that their Department of Education has allowed and is optimistic about pushing forward is the Secondary and Post-Secondary Education Reform Act relative to funding. So what that means to us and what that means to you is there's money that's available through the federal government for us to distribute to you. We have about $140,000. What that looks like, nobody knows. Of course, and I say this with all due respect to the United States government, they have these plans and they don't necessarily know how they're going to implement it. But I'll just say this, it's $146,000. And what we intend to do with all of our students in adult ed is figure up a formula. And we've developed a couple different options on what this may look like so that we're inclusive to everybody in every program, the paramedics, the fire, you know, welding, HVAC, you know, all of those programs, CDL, and what it might look like. And essentially it's money that we're going to provide to you. It's through a G5, not to get in the weeds. It's kind of like talking about A&P. I can really get into the weeds about that. But suffice to say, as soon as we get approval from our attorneys on how to distribute that, we're going to distribute that. But everybody, with the exception of anybody that decides to drop out, is not going to get it. And you can use that money for whatever you want. So round figures, it could be, again, there's a lot of different models out there. So I'm going to say between $600 and $800 in that area when it's all said and done, and it'll go directly to you. I don't know how that's going to be, and forgive me, I just don't have the answers on how, if we just cut you a check, we deposit it, we offset any expense. I don't know that. So, but this has just come about. So the grant got approved. Well, it got pushed out by the government on 10th. We got yesterday. So we're getting more information about it. We have applied, but we don't know. So bear with me. So anyway, those are some of the things I'm working on. I hope to have more answers about that, but I did want to pass that along to you. It wasn't anything that we had to apply for. It was given to every post-secondary institution in the United States, and their award was based on FTEs, which is full-time equivalents. It was based on students and hours and so forth and so on. So in the interest to be fair with everybody, we wanted to be inclusive. We didn't want to just say, well, you know, you have more of a need than this person, so we're going to distribute that money, 1% of it, to the students. So Any quick questions on that or anything that I've rambled on for a couple minutes about? I'd be glad to take any questions. Please tell me yeah, it's on. Man, I was telling, oh man, I hope I wasn't muted.
I've done that twice now. No, you're good.
Nothing? Yeah, so just stay tuned. I don't have all the answers. I want you to know that we're working on your behalf, and our safety to the students and staff is of paramount importance. So I know Adam's going to take good care of you. He's a gentleman, a scholar, and I know that everything that he does is student-centered, and I can tell you that we're to have him and you as part of our organization. So keep an open mind. This is more individualized instruction than anything. So I didn't have this when I went to another school in 1990. So that's 30 years ago. So anyway, stay focused. If there's anything I can do, does everybody have my cell number, Adam?
I can see to it that they do if you'd like.
Here, I'll just throw it up there in the chat. How's that?
Sure.
And be advised, I don't answer a phone unless I know who it is. No offense to anybody, but I get a lot of scam phone calls. So leave a message. I'll call you back. It may not be in 5 minutes, but I always return phone calls. My wife will tell you that ad nauseum, late at night, early in the morning. That's my personal cell phone. So, and my email is Trevor J. I may not have all the answers at this point. I'm working on it diligently. I don't want you to think that there's not a minute that goes by during the day that we're not trying to figure a way to get our students and our staff back together. We have to do it safely. We have to get permission from our regulatory agencies, and we're doing everything humanly possible to deliver the content in the best possible way for you guys. So if there's anything I could do, please let me know, and stay tuned for, I'm guessing your email went out. So I don't know, I don't regulate that, but if there's anything I could do, anything that we can do to make it better, communicate with Adam, and you don't get the answers you want from Bill, or you just want to chat about anything, feel free to call me about anything. I'll be glad to entertain your phone call. So thanks a bunch. Are you guys going on break now, or what? Or just coming back from break?
Check their email and phone call.
What's that?
Yeah, we'll take a quick break and let them check that email and phone call and
okay,
them go through that.
Great.
All right. Well, I appreciate it. Thank you much.
Yep.
If you guys can give me about maybe 10 minutes, and I'll be right back. We'll finish this up and we'll jump right back into the communication where we should be today anyway. Any questions on any of that other stuff? Probably not. We covered it pretty good. All right, cool. We'll see you guys in just a little bit. The big thing with Alzheimer's, once we get into it, Alzheimer's is going to mask a lot of the problems. The people that we're talking to that have Alzheimer's can't really give us a good history. So they may be having a cardiac event, but they tell us that their back hurts or something just because they can't figure out the words to use to express what they're having. So Alzheimer's, as we get into medical, it's going to be awful. It's just kind of a terrible disease to kind of watch. Psychiatric disorders, they are their own problem. We'll talk about this later too. Schizophrenia is multiple personalities, and bipolar is hot or cold. You can wake up happy, and by the end of the day, you're frustrated. And in between, you've gone back and forth on that spectrum several different times. There's medications for both of them. The latter, the bipolar, is a more commonly treated one. Schizophrenia, there's so many different levels and flavors of that it's hard to determine which one somebody has to be able to treat it. Stress and disease, we talked about the stress and the physiological response to stress. We know that basically at the end of the day, there's a stress that happens to the body. Everything ramps up. We know that the pituitary gland, it dumps off a whole bunch of adrenaline. As it starts to dump off adrenaline, then we start to have a full systemic reaction to that. So our heart rate goes up, our pupils dilate. It's that whole fight or flight. And that's pretty much all I really want to go into on that. This general adaptation, this is this is kind of a whole nother ball of wax, but it basically has to do with your body's response to the stress. So really at the end of the day, there's that initial reaction. It's that initial alarm, like, oh God, something bad's going on. As promised, that stuff at the bottom happens. So we start to constrict the muscles, constrict the all of the vessels, because we want to try to make sure our blood pressure is as high as possible. And that starts to wreak havoc on the system. We start to dump in more glucose because, again, we know glucose is responsible for that ATP that allows muscles to work. So we fully think that at this point we're getting chased by a bear. So we need as much sugar and as much stuff as we can physically pump into the muscle tissue so that we have plenty of energy to work off of. And then at some point we have this plateau period. And this resistance plateau is basically where our body starts to try to, it tries to release as many of the hormones responsible for feeling, so that we can be scared, so that we can be aware and hyper aware to surroundings and stuff like that. So this basically is responsible for getting our brain right. So our body, as you can tell, our body reacts before our brain does. So that shows how important being able to be aware of this stress. And this even goes back to the PTSD stuff that I talked about before. This is our body reacts before our brain even knows it's reacting. So this is kind of to show that. So as the brain starts to catch up, you can start to rationalize, like, okay, so I'm not really being chased by this bear, but it just feels like it. So you can start to rationalize that stuff. And at a certain point, the adrenal glands and the glucose has been used and your body starts to come down. And as it starts to come down, it takes almost twice as long to come down as it did to go up. So you start to, your body starts to kind of go back to that homeostatic place that it likes to be in. So if your body is susceptible to the chronic stress, this is a normal reaction to these people. So these are the people that have chronic anxiety disorders or things related to that. And this goes into a whole nother world of everybody responds a little bit differently when they have this. Just know that there is a chronic stress reaction that over time you don't necessarily react as strongly as you once did, but in some cases you can. Some of these people they have a hyper reaction, so they end up some small trigger would truly set them off. But that's a normal. This refers to the normal chronic state of that, and I don't want to go too deep into any of that stuff. We talked about coping mechanisms back with the other lecture, and that's really all I wanted to hit on that. All right, so what do you got on that? Anything good? Anything bad? Anything awful? No?
And I might have one question.
Yeah, what's up?
So basically, anything foreign that enters the body is broken down into those two things, either the T cells or the other ones.
I think I missed the first part. Anything that enters the body is called an antigen. So anything that's foreign to the body is an antigen. What the body does from there is it decides whether or not this is going to be an allergic response, which IgE and mast cells will be responsible for, or it's going to be more of an immune system response. If it's that immune system response, so it's a virus or a bacteria or something like that, your body's, the T cells are going to notify it, and the T cells are going to have the B cells create antibodies for it. And then those antibodies are what physically bind to that antigen to form the complex. They call it a complex. So the antibody and the antigen come together, they form a complex, and the white cell kills it. Does that answer your question?
Yeah, you're good. You're good.
And honestly, that is a rehash of the whole 2.5 hours that we've spent on this mess. Like literally, that is exactly what that is. And if that is still not clicking with you, I need to find a better way to give it to you. And if that's the case, please let me know. And if it's now, then you're probably not the only one confused. So please ask it if you need it. Are we good to move on? Okay.
I had a question. You said that the body is able to react before the brain actually processes it. How does that exactly work?
So that's the cellular system. That's that whole these T cells that are floating around, and specifically with a fever, you can think about a fever. The second let's go back a step. Let's use this COVID. COVID in general, once it gets into the body and once it gets into the bloodstream, it takes about 7 to 14 days for this incubation period to happen. So that means if I'm exposed today, I might not have any symptoms at all for 7 to 14 days. Well, in 7 to 14 days, that's not that I don't have it. It's just that my body is still figuring out what to do with it. So unknowing to me, completely unbeknownst to me, my body, my T cells have found it. They found this COVID, this piece of work that's floating around. The T cells found it. The T cells said, hey, they called up the B cells and said, hey, produce an antibody that's going to fight this thing. And they're going to go, I have no idea what to do. Don't have a clue. No idea whatsoever. So since the B cells can't produce an antibody because it doesn't know what it is, it's going to go back and forth in this system to try to figure out what it's going to do. On a cellular level, what ends up happening is the white cells go looking on their own. The white cells go out and say, there's this thing, we don't know what it is. So we're going to start looking slow but sure to try to kill it. We don't know how we're going to do it yet, but we're going to try to do it. So in the meantime, those being the T cells that are responsible for identifying them will point them out. They will mark all the cells, all the COVID cells that are floating around your body system, but your body has no idea what to do to actually fight it. So that 7-day window, or that 7 to 14-day window, is when your body finally says, okay, this is the plan we're going to do. We're going to send all the white cells to it. We're going to activate the mast cells because we want to shunt blood flow to the skin, because that's what they're dumb. That's what they're going to do. And you end up with this full systemic reaction from there. So again, it doesn't know, but all this stuff is happening behind closed doors before your brain's even notified that there's a problem. So at the 7-day window, your brain now knows that there's a problem. Your brain knows that, oh my God, I got this fever and I got this reaction, I got this response. So that is kind of what I was talking about with that, with your body being the last, or your brain being kind of the last to know. With the stress, as soon as there's a stressor in the body, the stressor activates that cortex that releases that adrenaline. So basically, the body knows that there's this god awful thing that happened. And again, we'll call it a bad car wreck. There was this bad car wreck where maybe, God forbid, a child or something dies, something that really tugs at your heartstrings. You're going to process that and go, I got to do my job. I'm going to do my thing. Well, in the meantime, your body is dumping all of these hormones, all these feel-good hormones or feel-bad hormones, into your body because of this stress that it just dealt with. You're going to go through, you're going to make the run, you're going to do your thing. And then afterwards, when you have time to think about it, it just starts to escalate. So by the time it escalates and you start to feel anxious about something, your body has already dumped the hormones. It's already dumped hormones. It's already dumped adrenaline. It's already dumped everything into the bloodstream. And your brain is starting to pick up on the physiological responses that your body's making. Does that kind of make sense?
Yeah, that makes sense.
Okay. All right, cool. So that's it for Patho. If there's no questions, Patho is one of them things that you guys, I promise you will forget. And that sucks, but that's truth be told, that's what's going to happen. You guys aren't going to remember any of the stuff that you've gone through, because at the end of the day, we're going to start talking about specifics. And when we start talking about specifics, like as it relates to the cardiac system or as it relates to respiratory, we'll bring this stuff kind of back in small chunks. But realistically, I'm not going to test you on cellular crap unless we're talking specifically about cellular crap that has to do 100% with with the body system that we're actually working on. Is that fair? Does that make sense? All right. So we are behind. We're behind 2 chapters. We should be doing 2 today, and I think we're only going to do. I'm gonna blow through this one. There's only 60 something slides. And I hate the death by PowerPoint thing, and I'm not really sure how to fix that right this second in our current state. But so we're gonna cruise through this. So we're shifting gears completely out of the body. You've got all you can digest from the body right now, and that's plenty. So with this, if I can figure out how to make my computer work, give that a shot. You guys see that? All right. So communication. This is going to be a really, really important chapter once we get into more of the operational stuff. So once we start talking about just general ambulance operations, the operational chapters for FISDAP, the operational chapters that you'll be tested on in National Registry. Communication is something that they do like to ask questions about. None of this is going to be super crazy earth shattering to you guys. Communication in general with the fire departments and in our line of work sucks 100% of the time. And that's internally, that's with dispatch, that's with our patients. Communication always sucks for us. But because it's so vital for us to get the information, it's kind of the core of what we have to try to figure out how to circumvent. So knowing how to talk on a radio, knowing how the radio system works, knowing how to communicate with our patients more effectively, and how to just in general, what some of the barriers are to that communication. That's kind of what they want you to take away from this. Just out of curiosity, is anybody bilingual or then some? What languages, Alex?
I speak Spanish and Italian.
I'd have never guessed. Savannah?
It was a joke. I don't know anything.
You speak that knob, don't you? That Hamilton.
I have a different way to communicate.
Speak that Hamiltonese. Fairfield Township. Anybody else? Nothing? Good. So being bilingual, I speak Spanish, and that's truly if you don't use it, you lose it type thing. The military does a really good job of taking some of their translators, even some of the higher level teams. They will go out and they're expected to translate, to a T, but then when they go home for a year or when they're out of deployment, they lose that. So the military, some of the upper level operatives that do military stuff, they once a week they have to call and they talk to somebody in that language about whatever for like an hour straight. So it's kind of tough. So for us as providers, it's not uncommon for us to pull up on a car wreck and there's 4 Hispanic people in the car and you have to try to figure out a way to communicate with them. So knowing a little bit is specifically of Spanish right now. There's some other languages that are becoming more prevalent in this area, but right now Spanish is probably still going to be a pretty big one. Just being able to say, sit the hell down, lay down here. Basic stuff. Once we get into some of the as you learn some of the stuff through the class, it wouldn't be a bad idea for you guys to kind of just keep a running idea of how to physically say, I'm going to start an IV, or you're going to have a big pinch on 3, or whatever it is. But as you start to get that stuff figured out, or as you start to kind of write that stuff down, it's going to help to kind of commit that to memory. I can tell you that we've got a trailer park that's probably 30 or 40% Hispanic. Some of these populations, Hamilton has a very, 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 very densely populated Hispanic area, and everybody tends to have something like that. If you don't already, Google Translate Google Translate's a free app, and within that app, it's actually kind of neat because you can save or favorite certain terms. And you can just physically speak in English and it'll automatically translate it to Spanish for you. So if you're sitting at the bedside and you say, where do you hurt? You just turn the phone around to them and it's already translated what you said into Spanish and it's showing on the screen. So Google Translate is pretty cool, and you can change that to any other version or any other language. So that's kind of cool. Just for that. Now, I guess it's important to note that is not an official medical approved communication thing. But to be honest with you, at 2 o'clock in the morning, back of an ambulance after a car wreck, I don't particularly care who regulates it. I just need to be able to communicate somehow. Now, I might not want to go too crazy on giving medications if I can't truly figure out if they're allergic to them. But just some things to think about, just kind of tools for us to use. So here's the typical communication pathway, and if you've been through college and taken any communication classes, this is a very, very common thing. You will probably be tested on this at some way, shape, or form. There has to be this particular feedback loop is pretty important for us to be able to understand. This is on page 135 if you're in the textbook, but there has to be a sender that sends the information. There has to be an actual message of some kind. Somebody has to receive it, and they have to give you feedback. This is how all of our calls are going to operate anyway. There's going to be one person in charge of a call. So let's say a cardiac, let's say a non-breather. There's somebody in charge of that run. So, and it's going to be you guys during your capstone. So towards the end of this class, you guys are going to be in charge of these runs. So you'll sit at the head and you are literally just going to be yelling at people to do stuff. So you are the sender. You tell them what to do. Somebody hears what you just told them, and they repeat it back. The medical community in general, they want us to repeat that stuff back, specifically as it relates to drug dosing. So if I say give 1 milligram epinephrine IV push, you'll repeat that back. Okay, 1 milligram IV push epinephrine. And it sounds silly right now, but this is actually what we should be doing in the field. There's been 3 cases that I can think of in my ambulance in the last month where the medication that was handed to me was the wrong medication. So that's a big deal. And you know, for me to be able to repeat that back and for them to repeat it back to me, that eliminates this kind of error that we're worried about. And a lot of times it's just a learning curve, but if just a simple communication feedback loop is going to be pretty important for that. So we talked about some of the barriers. I know there's elderly, there's hearing, there's visually impaired people, there's language barriers, there's people are all hysterical. We're not dealing with people on a good day. I mean, this is obviously a bad day for them if they're calling 911. So we just have to be able to try to improvise, adapt, and kind of overcome on it. So as far as our 911 system, when we have some time, I'll play it. But as I mentioned in the past, I started in law enforcement. So I did the cop school thing for a little while, and then I got out of that. And my transition from law enforcement to the fire service was through the communication center in Hamilton County. So I was a 911 dispatcher for about 3 years for them, and they paid for my fire school. So I've got some pretty neat calls. Some are funnier than others that I'll play at some point from our friends at the 911 center. But basically, if you think about it, you're sitting at a desk, and if you're us in a very, very informal way of explaining it overnight, we're tethered to our desk with a headset, and we got creative. You can play. I can tell you that within 12 feet, tethered to my desk, I can play cornhole, wiffle ball, home run derby. All of that stuff is a thing that can happen in that 911 center. So when you think they're just poised and sitting there just waiting for the next call to come in, you are incorrect. They are doing everything but that. But at a certain point, when someone calls 911, it will buzz in your ear. There'll be some kind of tone, and then all of a sudden somebody's there. So you're laughing, you're joking, you're hitting home runs, you're doing whatever you're doing in the dispatch center. You get the beep beep, and then somebody is just screaming bloody hell on the other line. And then you got to try to figure out what to do. So you're shifting gears. If you're me, you're fat, you're running back to your desk because it's all the way over there and you're 12 feet away. And then you're trying to figure out what's going on. So these people are hysterical. It'd be weird if they weren't, because they're calling about some type of emergency. So they're trying to explain this god awful thing. They're panicked. You can't see them, so you can't see body language. You can't read lips. You can't do any of that. You're just trying to listen through like blood curdling screams. So they take a minute, and it usually takes them a couple seconds just to kind of get the bearings of what's going on. And then the hardest part is just getting an address. They just need to try to figure out where the hell this person's at, and it's more difficult. It's harder. You know, it's easier said than done. Now, technology is great. There's been a lot of advances in that. When you call 911 from a cell phone, within about 3 seconds, 3 to 5 seconds, the dispatch center will have a little pin that drops on a map that shows exactly where you're at, and that's within 3 meters of accuracy. So if you're literally in a ditch somewhere, they can figure out pretty much where you're at. If you're calling from a landline, the Cincinnati Bell and whoever, they maintain a registry, so that, you know, as soon as that 911 call comes into the communication center, it literally will pull out address, name, phone number, and all that stuff and stick it right into your computer's CAD system. So that's a automatic system. And then usually within about 30 seconds, the dispatcher is supposed to go from taking the initial call, from the initial call to physically dropping tones for us. That's about a 30-second window. So in 30 seconds, they have to try to calm the person down enough to understand them, figure out what the problem is, figure out where they're at, and send it. So usually what ends up happening, and most systems are the same, I can speak for Hamilton and Butler County, but most systems are the same, where you'll get that initial dispatch, and it's very, very limited, because that's really in 30 seconds all they've been able to acquire. Once you go en route, you usually get some type of additional information. That is the 3 or 4 minute difference between dropping the tones and you keying up on the radio. They've had 3 or 4 minutes to talk to this person, try to calm them down and figure out what the hell is actually happening. So on the 911 center, their whole job is figure out what's going on, physically where they're at, and then what resources to actually send. And they got to try to make all that happen within, like I said, about 30 seconds, and then they have to try to play the catch-up game thereafter. Any questions on that? All right. So we use radio signals, we use numbers. Some people use like 10 codes, and there's all kinds of other weird stuff. There is no nationally recognized system for any of this. We know that we use radio. You're assigned a station number, a unit number, a department number, a truck number, whatever it is. You're assigned a number, and that's the number that's used on the radio. They talk about, so that's what the departments have. They have a system, they have a device, they have radios, and they have some kind of clear communication guideline that's out there. On the comm center, they need a backup system so that if it goes down, there's some kind of backup system. I know Hamilton County, if there's a problem with Hamilton County, they can throw a switch and it'll automatically divert all radio traffic and all phone calls to the city of Cincinnati, to their communication center. And there's something similar in Butler County. So there is a backup system in case something goes down. The important stuff to know here, without getting into like nerd talk, is that FCC is the communication center, that they are the regulatory body. So if you're ever asked about who the communication regulatory body is, or the federal regulatory body, it's the FCC. That's really about it for that. Yeah. So as far as the actual communication, there are two types. There's two types of devices anyway. There's a receiver, which is just the minuters that we used to have that you wear on a belt or a pager. A radio signal comes in, it activates, but it doesn't. You can't key up, you can't talk out. And then there's the two-way radio that we're all familiar with. I'm going to move through this kind of quickly, and I'm going to pick out the high points. And if you are like an avid note taker, I'll tell you what to write, just so that all the bases are covered. But a base station is in the station, mounted in the station, and this is usually tied to your house tones. Mobile receiver, mobile transmitter, that's obviously the in-vehicle mounted unit. That's not necessarily what this fella here is using. He's using a portable, which is the portable transmitter. Battery powered, they're not quite as strong, and that's really it for those. So the radio system, we're going to talk a little bit about the radio system, and you do have to know these. This will come up. This will come up again. I don't know why National Registry likes to ask it, but they do. And you'll hear that from me a lot. Again, I've told you before, I try to take this test as often as I can, just so I know what to tell you guys to study and what's on it. And this is some of the weird stuff that they like to ask. So radio systems, there's 4 different types. Simplex, duplex, multiplex, and digital. And we'll talk about that kind of individually here in just a sec. If you guys are using the book, I try to follow along in the book so that if there's specific things that I can show you or have you look at, then I'll be able to kind of kick you back to that. So again, we'll get back to the radio systems. So the repeaters. Repeaters are exactly what this picture shows. I'm out here on a little fire truck. My radio can only transmit so far. My handheld can only transmit. It's even less than what my mobile can transmit, and the mobile is far less powerful than like the base station in the firehouse. So the whole idea of these repeaters are all over the county. The whole idea is that my portable needs to be strong enough to get me from wherever I'm at in the township or in the city to hit that first repeater tower that's closest. Once it hits the repeaters are plotted out on a map by a bunch of engineers. They know how strong that repeater is and how far it can transmit. So basically, once I hit that repeater, the repeater is going to continue to bounce from repeater to repeater to repeater until the final recipient gets it. If that makes sense. And actually, I don't know that this is going to go back in. I'm gonna go back a slide because I do. If you guys wrote this down, I do want to kind of hit on what these are because I don't know that we're going to get back to it, and I don't want to leave you guys hanging on that. So basically, the simplex system is there is one radio channel. When I key up every single time, that's going to go out on the same radio frequency, the same channel. So if you go to Walmart and buy a set of walkie-talkies. They're usually programmed with several different channels, but every time you key up, you're on the same specific channel. Does that kind of make sense? All right. Duplex is there's a send and receive channel. So when you transmit, when I push the button to talk, I go out on one dedicated channel. And then when I hear something or when that radio signal gets back to me, that's on a separate channel altogether. So if you were sitting in front of a scanner where you could program your radio to hear or to transmit whatever you wanted, if you set up either one of the sending or the receiving, you would literally only hear that particular channel's stuff. So you're only hearing transmissions from one side, or you're only hearing the repeat, the bounce back from the other radio. I'll give you a sec to write that down. So multiplex is more of it's a trunking system is kind of what they kind of have evolved into. But multiplex is there's a bank of channels that constantly rotate. So when I transmit, as soon as it's going to continue to rotate until I push the button. Once I push the button, it's going to lock on whatever channel it's cycled to, and I'm going to transmit and receive on that channel. What that does is every time I key the mic, there's a potential for me to be transmitting on a different channel. This is where encryption starts. So if you don't want somebody to hear your stuff, you can kind of set it so that they can't 100% reliably hear you, because you're always transmitting on a different channel. That's what multiplex is. So again, simple is one channel. Duplex is a send and receive channels. That's two channels. And then multiplex is kind of a bank of channels that kind of go through. Does that kind of make sense? I hope. Yes. So then digital is essentially it's more like the internet. You're sending not necessarily on a frequency per se, but rather you're kind of sending on. It's more of an analog system. So basically, it's more like Wi-Fi. You're transmitting not necessarily on a very specific channel, but rather it's more on a network like a cell phone is.
It's like voice over IP, right?
Yeah.
The voice is digitalized, sent through the network.
100%. That's exactly voice over IP, which as it relates to this chapter is, by the way, that's a nightmare for our comm centers. Voice over IP, you can do that at your house. You can pay for a subscription and have one of those voice over IP phone numbers. The problem with that is you're 100%, you have to register that to your address. So if you move, you can take your phone number with you, but it's still registered to your old address. So that's where your 911 calls are going to get routed to that particular call center. So that can be somewhat problematic. But so digital, and that's really all. I don't want to go too deep into that. That's pretty much what you need to know for that. So the repeaters, we know that it bounces the signal from the truck along the repeater system until it finally hits that final destination that we need to get to. They try to put those again at relatively high elevations. When you go around, a lot of times when you see the cell towers, the cell tower that's owned by Verizon or whoever, they're going to have there's another antenna that's on that you wouldn't even be able to identify that happens to be a repeater for the county emergency system.
This is kind of like a weird question, but I've always wanted to know, what is Nike Tower?
What is it?
Nike Tower, like when we're dispatched and it pings off Nike Tower, like I don't even know what the heck that is.
I don't either. That's a good question. You said you see it in like Active 911?
Yeah, so it'll be like Nike Tower, like it's on the bypass somewhere. I just don't know what it is.
That's interesting. Yeah, I don't know. I haven't even noticed that. That's a good question. I have no idea, but I shall find out because that's cool. So the whole idea, and maybe it's just that I don't even know how it would be owned by them. Yeah, it doesn't make any sense. That's interesting. So as far as repeaters are concerned, I think that's really all. That's all you guys really need to know, is that all it does is it repeats the signal from tower to tower, from the portable to the tower, and then from tower to tower. Encoded radio channels. These are locked frequencies. So if you're in let's say Butler County, you've got there's some channels that are open to the public, and then once you get into some of the other encoded channels, you can't necessarily transmit out with anybody being able to hear. It would just be a digitalized mess from the other side. A lot of the law enforcement channels are like this. They keep them super locked down because they don't want criminals being able to hear what they're doing, specifically if they're being chased by somebody. So they want that to be somewhat encoded. But what that does is basically it locks it down so that just the intended users get access to those frequencies and nobody else can. A trunking system really starts to get kind of down somewhat into the weeds. The easiest way to think about a trunking system is that there's a whole bank of sending channels. There's a whole bank of receiving channels. Most of our radios, there's roughly 20 of them. So there's 20 receiving channels and 20 sending channels. And of those, parts of your message can literally be sent on different frequencies within the same transmission. And really what that's going to go back to the easiest way to think about a trunk system is there's a whole bunch of frequencies. You have no idea. You cannot reliably or predictably figure out which frequency you're going to be transmitting on. And you're not going to be able to reliably predict which frequency you're going to receive it on. The end user, when I pick up my portable and I push the button and I talk, I have no care in the world what any of this stuff means. But if you're the nerd sitting in the basement that's trying to figure out where the police officers are going, it's hard for them to put all this together because these trunked channels, they rotate, they alternate, they change. It's really hard to narrow that down. But there's software within our radios that are designed to decode this and basically make it just a seamless walkie-talkie for us. And that's really it for the trunk system. So dead spots, we know some of our businesses, again, our whole goal with a portable radio is to be able to hit the closest receiver, or the repeater rather. So Children's Hospital is in Liberty Township. In the basement of Children's Hospital, there's some pretty significant dead spots. And some of those dead spots, you really have absolutely no ability to actually hit that tower because you can't even get out from the concrete walls. Mr. Camburn, why don't you bring that out? Let's hear that. Put your propeller hat on. Let's hear this.
Well, it's no longer like owned by the Army Corps of Engineers, but it looks like they used to have a missile test site in Oxford called Nike. So it's probably just relating to a repeater on a cell phone tower in that area.
That makes a ton of sense. That's actually really cool.
Because we'll get injury crash at Nike Tower and it's bypassing Princeton. So I guess our repeater's right there.
No kidding. Yeah, that's pretty neat. So the comm center, when they get that, usually, like I said, 3 to 5 seconds, they have a pretty isolated spot. When that 911 call comes in, the initial data package that they get from that cell phone provider is whatever tower it comes from. And then it takes 3 to 5 seconds for their computer system to re-query where they're at to get the very specific, that within 3 meter location that we were talking about. So likely what happens when they call 911, the first initial location that they get is going to be that tower. So that all makes a ton of sense, I guess, putting it all together. But yeah, I didn't know anything about that. That's pretty neat. So where were we? So interoperability. So this becomes a challenge specifically when you border another agency. And again, I like to use Liberty because we're so weird in so many ways. But we border not necessarily Hamilton County, but we border Warren County. We border several different municipalities that have their own dispatch center, and places like you talk about Hamilton County. Hamilton County borders in some places Indiana. They border Butler County. They border Kentucky. So there's a whole lot of different things that they have to try to deal with. So just trying to make all of our radios talk together is somewhat of a challenge. So if you work in Butler County or you live in Butler County, some of the agencies out west, like College Corner, it's not uncommon for them to go into Indiana. Well, Indiana doesn't have our channels programmed into their radios. So what they end up doing is they have to create this link. They call it a patch. So they'll tell Indiana to go to channel 1, and they'll tell us to go to like one of our Fireground channels, and then the comm center will go in there and link those channels together so that they can communicate between each other. So that's really it for that. The P25, the Project 25 is it's more of a radio hardware standard, and I don't care much about that. It basically gives the wattage and the power that each radio is supposed to live by. If you're a ham radio person, this is all normal language to you guys, but for the rest of us, it's not so much. SafeCom is a Homeland Security initiative that prevents our radio channels from just being out and about to anybody. Cell phones, we talked about that. Speaking of cell phones, there's a lot of talk right now about FirstNet from AT&T. Some of you guys might already have it. Basically, what we decided was because everything is used, all of our radio communications and all of our cell communications go through a tower. We've determined that during a national emergency or some local emergency, that so many people are using the phones that they're literally, there's no channels left to go out on the repeater. So FirstNet, what they did is they basically said that anybody that has FirstNet has priority. So if all the channels that particular tower is designed to transmit are full, when somebody that has FirstNet tries to make a phone call and hits that tower, it will literally bump somebody else off of it. So it'll hang up on them one other line to allow you to have that line access. Verizon and all the major carriers have some version of this. I don't know that it's necessarily, they swear it works, they say it works, and I don't really know. There's no way to really tell because fortunately we don't have to deal with that on a regular basis. But just know that exists, and that's a kind of a benefit for us. You would just contact your cellular provider and tell them that you're an emergency responder, and really this is just it's just priority access to the cell lines. I would be very, very cautious about taking any photographs or videos from your cell phone. Be very cautious about that. The second you take photos from a legal standpoint, that whole phone is now discoverable in court and everything on it. And I generally feel like most of us have stuff on our phones that you probably wouldn't want to show up in a courtroom. So keep that in mind. GPS, medical applications. If you didn't know, a lot of people are starting to use ICE. It's that in case of emergency contact. So if you have access to somebody's cell phone and you search for ICE, that is their emergency contact. With Apple, even under a lock screen, if you have an Apple phone, you can still see the emergency contact or the emergency information at the bottom, even on the lock screen. That's super important if the people take the time to set it up, which for you guys, I would strongly encourage you to set it up for your personal self. But that's like your allergies, what hospital you want to go to, who your emergency contact information, like the people are. It doesn't give you access to your phone because it's even with the lock screen, but it still gives you the ability to put out personal, whatever personal medical information in the event that you're not able to give us something. Crash notification, this is OnStar. So the car crashes, what happens? So when a crash happens, the airbags deploy. When the airbags deploy, it triggers another sensor in the car that will transmit to a dedicated facility with the dispatcher. So OnStar gets a phone call that says, hey, this particular subscriber, we just got a crash sensor notification. Here's the location. And they automatically call 911 on that person's behalf. There's it's limited information. Some of the OnStar systems, actually most of the OnStar systems, as soon as that activates, there's a microphone that activates within the car. So without any input from the driver, the OnStar rep can get basically in the car speakers and say, hey, are you okay? What happened? And if they're able to communicate, they can communicate, and then OnStar will pass that through to us. Satellite communication, we don't use really a whole lot of the satellite communication systems, just know that they exist. You can set this up on your own. When natural disasters happen, part of what the emergency response network and what the emergency systems do, we'll go down and we'll set up our own repeaters and our own, basically our own little SATCOM systems for us to be able to communicate from there. But that's really as far as communication is concerned. Other than that, we start talking about the global positioning stuff and the GPS, and I think we all know what that is. Backup systems, we talked about backup systems. Oh, I should also mention that if there's something catastrophic and Hamilton County, for example, their cellular towers go down, or I'm sorry, their comm center goes down. So 911 goes down altogether. I told you there's a magic switch in the basement that will kick everything to the city of Cincinnati's dispatch center. So Cincinnati, God forbid, if there's some catastrophic issue where they took out both Hamilton County and the city of Cincinnati's communication centers, there is this break glass in case of emergency button that will physically route all of the 911 calls to Daryl and Billy and all the other little, like the ham radio fellas that sit in the basement. And no kidding, they would be like the emergency response people, and their radio operated, their battery operated ham radios. So again, that's the god awful shit hit the fan, and now we're trying to figure it out from here. But that is like the final fail safe for a lot of them, is these amateur radio systems. Now these people are screened and they are trained in somewhat what we expect. But again, that's a last ditch effort for us to be able to communicate. And these people, they take this very, very seriously. They have like these conventions, and they have these, there's fairs, and there's like swap meets, and these people, this is like a whole lifelong calling. If you know any of these amateur radio people, they take that super serious. Do we need a little break overall, or are we good to just keep rolling? Anybody want to take a break? No, maybe no. Okay. So let's talk about this then for a minute. So biotelemetry, this is becoming more and more prevalent, and as technology starts to increase, this is good and this is bad. So basically, you get a defibrillator that's placed. If you lose consciousness and your defibrillator fires, there is a notification system that's based on a cellular signal that will ultimately transmit and call for help for you. This is based 100% on your vital signs. So all of a sudden you lose consciousness. There's usually some type of shock indicator, like physical shock, like they fell, they hit the floor. So there's some type of motion component to it. And then it will absolutely notify for some type of problem. Not necessarily the notification side of it, but there is all pacemakers, you can interrogate them with a little magnet machine, and it'll pull the data out of them. That's how they get the data out of pacemakers. Some of the neat advances in that, I do a lot of the fire investigation stuff. We had a fire in Middletown several years ago where the guy set his house on fire. Long story short, he denied it. We got a warrant to actually pull the data from his pacemaker. So when he said that he was physically sitting in his car watching his house burn because he doesn't know what happened, there was a sharp spike in his heart rate. That happened to coincide with a story from the neighbor that said they saw this dude jumping out the window with a gas can, and right after he had set the house on fire. So again, this correlated that story, because we could biometrically, we could show that he actually had, where he should have not had any kind of increased heart rate, we were able to prove that he actually did, and that he was physically active at a certain point where he said he wasn't. And that actually made the story, and that actually made it all stick. So this is a blessing and a curse if you're not for good. But this is something that we're starting to use more and more frequently. There also, there's Holter monitors that you wear. It's an external 12 lead. You can push a button, and that button will like anytime you feel that palpitation or something weird go on, you can push a button and it'll capture your 12 lead at that very moment. And a lot of those are tied to a cellular signal that will then transmit to the hospital. Communicating, we talked about that. Be appropriate. The FCC regulates a bunch of stuff. Just know that they live there, and they issue the licenses that allow us to talk, and they establish basic ground rules. You shouldn't get on there and cuss and scream and make fun of people on the radio because they don't like it. They ensure that we have access to the channels. If there's a channel, if we have a problem with the channel, they have the ability to change the licensing to give us other ones. Obviously, they forbid us cussing and yelling and talking about personal stuff. This is basic clarification stuff. We know. So I'm gonna skip through some of this. Enunciate, speak clearly. I talk fast. People don't like that. You can talk a little bit slower so everybody can hear you. The calm and free of emotion is depending on you. We all have our radios and our stations where we can hear people that are not professional firefighters screaming and hooting and hollering on the radio. This is an example of that. Plain language is something that we're starting to go back to, but a lot of this is going to be department specific. Trying to keep it brief. Just in a nutshell, I had a mayday, and this is not necessarily story time, but we had a mayday situation. My partner fell through a floor in a house fire a few years ago. I could not get out on the radio. Could not do it whatsoever. So he's down in this hole. we're trying to hit our emergency buttons. They're talking and yee-yeeing about whatever they were talking about, and it happened to be water supply at the time. We had a lieutenant, and she was trying really, really hard to figure out this water supply, and it just never worked. But her constant communication on the radio about God knows what and everything, it prevented me from being able to call the Mayday that I needed to call for him. So just try to keep that in mind. That's kind of a pet peeve of mine on the fire side, because, you know, again, we're with the invent of like Blue Card and all the other stuff that we're trying to do for our scene size ups. We're starting to talk in like paragraph form again on the radio, and that kind of bothers me a little bit. So just kind of keep it in the back of your mind. Try to keep the transmissions brief if you can, specifically as it relates to medical stuff. And a quick example of that is the hospitals that we're going to be transporting to. Generally speaking, we call them on the cell phone, but we do have the ability to transmit via radio to them. And we can also get medical control advice from the doctor via radio back to us in the event we don't have a cell phone. So trying to rattle off a whole set of vitals, and, you know, if I keyed up and said, you know, I got a male 74, you know, we're in around 15-minute ETA, vitals are this, and this, he's complaining of this. Somebody on the other end's trying to interpret all this and write it all down, and God knows they can't do it. So try to be plain language, keep it kind of brief in small chunks that they can write down and they can kind of manage. Be concise. We talked about that. Be professional. 10 codes used to be a cop thing. It's not a cop thing anymore. Most of us don't use 10 codes. They specifically because the NIM system that we do follow discourages that. There's really not a reason. There's no reason to memorize a whole scale of numbers to say what you could just physically say with words. Moving through kind of quick. We talked a lot about dispatch already. I don't want to go too deep into that, but this is basically from us as providers to the comm center. There's usually some type of format that they want you to use. Some dispatch centers are better than others, understandably. And that's really it for that. So we're going to the scene. We tell them we're going to the scene. A lot of us have NDCs that we can use now to indicate that we're going to the scene. Tell them you're on scene. Tell them you're staging. Tell them whatever. I don't necessarily want to go through all this stuff because we all know. So this is now you're on scene, you're dealing with medical control. Again, a phone call is way better than what this dude's doing. This is not something that we should generally do unless we absolutely have to. Now I can tell you, like mass casualty stuff, MCI, you've got 2 patients in the back, your patient's critical. I can give you a whole bunch of examples why you can't pick up a cell phone and physically call the hospital. What we've been requested to do, and this is pretty much full thickness throughout the entire medical community, is if you have a shit show, you physically call them and tell them you have a shit show and you hang up. Like literally, they if you use those words, yes, it's recorded, but they have to know that there's some big catastrophic cluster that's coming into their ER so that they can appropriately prepare. I had a car wreck. There's a car wreck on 75 that had 7 patients. So 5 of them go to Westchester and the rest of them go to Atrium. So those 5 that go to Westchester, that very first phone call went something along the lines of, hey, this is Liberty. We're going to be bringing 5 patients to you. I probably have the most critical and this is my patient, whatever. Well, they know right away that they have to reserve 5 beds, and hopefully they hear from 5 individual ambulances while they're en route, but they may not. So just being able to activate that allows them to activate the resources that they need. So doing it on the radio, if that's all you've got, that's all you've got. It's not uncommon for us to have our driver call, basically just key up and say, hey, notify the hospital, you know, we got a 10-minute ETA with a non-breather, you know, whatever it is. And they generally, that's usually good enough. So when we're talking to medical control, or when we're reporting to the hospital, this is something that we're going to hit on heavily. You guys are going to have to make these telemetry phone calls in person and for testing with us. So these are some of the big things. I'm not really, I don't care for you to have like a full template for every single patient, but generally speaking, this is the kind of stuff that they're going to need to know. And this is all the stuff that we do already. How long is it going to take to get there? What kind of patient is it? What are they complaining about? Are they missing an arm or a leg? Are they not breathing? Medications and allergies, I'm not particularly concerned about that because the person on the other end probably isn't either. They just want to know whether they need to put them in a trauma bed or not a trauma bed, or whether they need to go to, you know, CT or the cath lab or something like that. The second to last one, the relative medical conditions or history, that's pretty important for us to say, you know, this guy's having chest pain. He's had 4 heart attacks in the past and this feels just like it. That's a pretty big deal. That's a good indicator that they should probably activate a cath lab at that point. And then the rest of the stuff, again, this is a case by case. You just tell them the story. You try to keep it as brief as possible. They don't care that they ate a bologna sandwich for lunch. They just care what your current crisis is and whether or not they're stable or unstable. A lot of times my phone calls are generally just age, gender, ETA, chief complaint, and then whether or not they're hemodynamically stable. And that's usually the phrasing that I use. The patient's hemodynamically stable. That means all the vitals are within normal ranges. They're all happy about it. Everything's good. They're alert. They're oriented. That's a real simple way of just saying all of this stuff. Try to be organized. You guys will struggle with this. You guys might right now today be awesome at making phone calls to the hospital. When you start thinking at that next level and you start trying to articulate your paramedicine treatments, that's going to change a little bit. It's going to be kind of hard for you to quickly, in some semblance of organization, present your case to them over the phone, because again, your mind is way ahead of where your mouth is going to be, and this is going to hold true pretty much for all of your patient assessments from here on. Your brain is going to be 4 steps ahead of where everybody else is, because everything is algorithmic. There's an algorithm, there's a protocol, and you got to check all these boxes, which, that's great until you have to try to articulate it, until you have to try to say it to somebody on the phone. The other thing that you guys are going to start to struggle with, and you might be awesome right now with bedside manner, but moving forward, your bedside manner is going to start to deteriorate, because in your brain, you've got 1,000,000 miles a minute going on with, okay, chest pain, nitro and aspirin and oxygen and, oh my God, 12 lead. And what is he doing? And there's this whole process of being in charge of a run that truly changes your interpersonal dynamics. So being able to communicate with the patient while working on this algorithm in your head is a completely different monster. So being able to kind of form your thoughts before saying it. A lot of your partners will probably notice that you're a little bit more quiet than you normally are on a run, because again, your brain is just smoking with all this stuff and all these cues and all this stuff that you're supposed to be doing. So just something to kind of think about for the communication side of it. So in person, this is when you go through all the details. This is no different than what we've already done. Medical terminology, a lot of times what I've found is the $4 words they don't care about. And if they don't care about it, some of the nurses, God love them, they might just not know what you're talking about. Some of the doctors, the doctors do, but the doctors don't particularly care sometimes. They just want to know what's going on. They don't care if you sound like an attorney. They don't care if you sound like a doctor. They just want to know what's going on when they take this patient. All right, noisy environments, we know. This is always going to be tough in the back of an ambulance, specifically with the siren on and maybe a window on or the vent open or whatever it is. It's tough. It's tough to communicate. We know that. We know when we're trying to communicate with people, there's active listening, there's responding, there's repeating kind of what they said. There's just general communication principles. Act like you care. Act like you're paying attention, and act like you're truly going to be that person that's going to take care of them. All of that stuff can be completely false, but you have to act like you care. And that's really what it's going to come down to. So having that good rapport is going to get them to somewhat talk to you. There's some patients, these drug overdoses, a lot of times they don't want to admit to you what they did. They know, and you know that they know, but at the end of the day, they might not physically say it. So arguing with them is not going to do anything for you. Be calm, be nice, blah, 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 blah. So elderly people in general, they do have a hard time hearing. There are days where you have to just sit in their face and scream. And you guys have probably seen that before. You just have to scream. They just can't hear. If you can put some type of assist device, if they have hearing aids, put them in. Things like that. Some of them don't want to talk if they don't have their dentures in because they're self-conscious. There's just a bunch of different things that would otherwise hamper your communication with them. Modesty is another one that we don't always do awesome with. In fact, I've always got a saying that there is no modesty in EMS, because there's times where you just physically have to remove clothing. You have to do a 12 lead. You sometimes have to remove a bra if it has a wire in it when you're doing a 12 lead. Trauma patients, if you don't expose their skin, you can't tell what's wrong with them. So again, there is no modesty in EMS, but the patient has to believe that you're trying to respect that. So, if you have to cut their clothes off, have a towel there, or have a sheet there, or have something there. We'll talk a lot about this stuff. Open-ended questions, I'm going to ask them, how do you feel? What does it feel like? Closed-ended questions, have you had this before? Yes or no. Closed-ended is the patients that can't really communicate very well with you. They're short of breath. If you walk in a room and you see a patient, they're clearly struggling to breathe, and they're one and two word sentences, please don't ask them to tell you a life story of any kind. That's just not going to work. I'm going to skip through some of this stuff. Be empathetic, blah, blah, blah. Again, a lot of this stuff is just human nature stuff. Clarification is something that we probably don't do enough of. The big example of that is if you're in the back of an ambulance after a trauma, somebody's bleeding from the arm, and they tell you that they have a factor 7 disorder. You can look at them cross-eyed all day long. This patient's going to look up at you and think, "Oh God, you're the doctor. You're going to know exactly. You know what factor 7 is. I don't have to explain it." Or some god awful 14-syllable disease process. They're going to look at you and say, "Hey, I got this," and you're going to say, "Right, gotcha. We're going to the hospital." You have no idea what that means. So please don't hesitate to ask them, what is that? What do you have? What does that mean? And a lot of times these patients, they've dealt with this. They've said this word 14 times, this week alone. They're being treated for it. Their whole life they've been treated for it. Just ask them to tell you what that means. Don't be shy about that. Nonverbal skills. This is what it is. Be nice. Act like you care. Again. Sometimes these special interview situations, these interviews, again, we're just trying to get the information that we need to treat them. I don't care about if this is if this is a legal scene, if this is, whatever this is, if they're in custody, I don't care about any of that stuff. I just need to know how to physically treat you. If they become hostile or they become combative, you leave. That will be a test question. I promise. That'll be written 14 different ways. And there'll be this god-awful wreck. There'll be somebody that becomes hostile. If it becomes hostile, you leave. Period. End of story. You leave. Acknowledging their concerns. This is all, again, there's all kinds of psychology lessons that can be built into this that I don't really want to get into. But that despite all of this, you are the professional. You're trying to manage this the best you can. If the patient is just flat out uncooperative, law enforcement might just have to be the way to go. Knowing that you're about to be a full-blown functioning paramedic in just a couple months here, or at least practicing as one. When you start having patients like this, we can chemically sedate them now. So you give them a shot, and in that shot you have some type of benzo that will physically put them down. That's an option. Frankly, honestly, if we're being honest, that's probably my favorite. Anybody that's anywhere near hostile, anybody that's worked with me, I love to sedate everybody. And there's no problem with that, because if they're sedated and drooling on themselves, they're not screaming at me. So I'm all about that. I can always, there's ventilatory concerns and stuff like that when you sedate somebody, but I've got a bag valve mask. So I'm not, again, when they're drooling on me, they're not a threat to me. So consider law enforcement, consider your chemical sedations, consider just strapping them down. We have restraints. But again, I don't like restraints. And you guys, once we get into that kind of stuff, we're probably not going to do a whole lot of physical restraining, because it physically takes manpower to do that. It takes strength. It takes technique. If you hurt somebody while trying to restrain them, that can come back on you. So a lot of times I try to shy away from that. If we can just pile on top of somebody while somebody sticks a needle in their arm or leg, and just back off and wait for that to work, that's a way safer thing for all parties involved. Again, safety stuff. If we're talking about safety stuff, again, the scene we will know. You'll either know by address that the scene is not typically a good scene. National Registry likes to ask a question where it's you respond to a known drug overdose or drug distribution house. Right there, it doesn't matter what they say from then on. This is going to be a safety question. The second anybody puts a test question out there that just says, hey, that this patient has history of being violent, or hey, that they're up to no good, one way or another, immediately thereafter, regardless of what it says about patient interaction and care and all that stuff, chances are there's going to be some type of you wait for police to arrive, you stage, whatever it is. But that's something to kind of keep in the back of your mind. Sexual assaults, sexually aggressive patients. This is just in general. There's a whole fine line in here for how you deal with these particular people, and that goes for the sexual assault patients also. There's and we'll get into all of that in medical, and I won't go too deep into any of that. When everybody's got the people that if they speak Spanish, we generally think that if you speak English but louder, they'll understand you. That's not true, I promise. We've got a couple of those, and I know you guys probably do also. You can't just scream English at a Spanish person. It don't help. So children and their protest, if you guys have kids, you know exactly what I'm talking about. Babysit, you know what I'm talking about. They will piss and moan about everything until they see a squirrel or something else, and a lot of times their mind gets taken off of that. So a lot of times with kids, distraction is one of the best things. In fact, Children's Hospital, they have a whole team of people. Their whole job, their whole career is around child psychology, and their physical job in the ER is literally to distract the kids. So they'll sit at the bedside and they'll blow bubbles. They'll play puzzles. They'll let them play on an iPad. I've got a battalion chief. His wife does that at Children's, and that's literally what she does. She walks around with a bag, and in the bag is just toys. And her job is just to simply distract the kids and find a way to communicate in a very childlike way with them about why they hurt, how they're going to get fixed, what the doctor's going to do before they do it. That position is called child life. So these child life specialists, that's really all they do. It's pretty neat. With kids specifically, a lot of times they're scared to death that you're just going to hurt them. They're scared to death that you're going to give them a shot. They're scared to death that whatever you do is going to bring pain to them. So if you smile, a lot of times they say start at the feet, because they can kind of control the feet. The closer you get to their face, the more real things start to get. So start low, start with talking to mom, kind of ignoring the child, talk to mom and dad. Once there's a rapport there, at some point the kid just will or will not do well for you. And this also goes back to there's a possibility. Oops, sorry. There's a possibility where you may just have to sedate them. Maybe the same thing as with the adults. They might just not tolerate you whatsoever. So try to stay at or below child's level. Don't be this big towering person with all this equipment, all this stuff that you're about to do. If mom can still hold them, fine. That's good. There's a little bit more trust there. We know that there used to be a day where we could strap mom to the cot and then put the baby with mom. That's legally frowned upon at this point. If you show up at Children's and the child's sitting in mom or dad's lap, there's some people with the social service department at Children's that are obligated to report you for that, and they will absolutely hang us out to dry. So be very, very cautious about allowing a child to be transported in mom's lap. That's a big no-no. Some of the weird caveats to that would be like a newborn. But again, even a newborn, if you think about it, if you get in a car wreck, that newborn becomes a projectile. And again, that's frowned upon. So we want to try our best to secure everybody the best we can. Moving on up through in pediatrics, we'll talk about some of the different periods in a kid's life and how their brain works. But as we start to kind of come to a close on this, we know kids are going to respond differently. We know elderly are going to kind of respond a little bit differently. We know that stranger danger is kind of a thing with kids, and a lot of it is if we can have mom or dad assist us in our assessment. By and large, that's a pretty important thing. If mom can take the child's shirt off, or if mom or dad can say, hey, do you hurt here, and you just kind of guide them to what you're trying to assess, that might go over a little bit better. But again, this is all case by case. So special challenges, this is people that can't communicate appropriately, whether it's Down syndrome, whether it's some type of mental disorder, whether it's some kind of physical disorder where they physically can't hear or see, or something to that effect. That's kind of who we're talking about here. A lot of times the caregiver, the family, they have a good ability of communicating with them. Some of the people that are nonverbal have a great, specifically like the high-end autism spectrum or scale, they can communicate with iPads or technology or something like that. And sometimes you just can't, and we just strictly have to treat 100% off of findings, so vitals and whatever else. So again, this is more common. So my little soapbox on autism, just in general, is autistic. The autistic scale is something that it's ever changing. But the problem is when you and I were kids, if you mouth off to mom or dad, you just get beat down. Like that's pretty much what happened to most of us. When you cross the line, when punches start getting thrown, when mom starts smacking you, when whatever. The problem is, as we progress into this kind of the society, the area that we're in now, everybody has to have a diagnosis. Everybody has to fit into a box. So kids that just have no discipline in their lives whatsoever, we can't blame that per se. They have to fit into this spectrum box. So maybe they're autistic, or maybe they have a sensory processing disorder. Maybe they have some kind of explosive personality disorder. There's a disorder or some spectrum of autism for everything. We know that some kids, maybe just socially, they're just awkward children. That as inappropriate as that is to say, they're just weird. So if they're just odd, that doesn't mean they have to fit into a category or a box. But unfortunately, medicine nowadays, there's Adderall. You just give them Ritalin, or you give them, whatever it is, ADD, ADHD. All of these things are boxes that we create so that on the medical world, so that we can treat. So again, when we were growing up, this wasn't nearly as prevalent as it is now, because now everybody wants a diagnosis. So that's kind of what they're doing. They're starting to broaden the diagnosis spectrum for these developmental disorders. So again, take it for what it's worth. The kid that you're dealing with, or the patient you're dealing with, may or may not actually have some true form of autism. It may just be this categorically placed thing that allow them to get medical insurance to cover medication to try to help them with their daily lives. Is what it is. Communicate through the caregiver if possible. They know, mom, dad, whoever, they know better than anybody else. Cross-cultural, and again, I promise you, this is kind of winding down. I don't want to spend too much time on this. Everybody ethnically, everybody culturally, there's different cultures that have different requests. A lot of the Indian cultures, they don't necessarily want men to talk to their spouses, to their wives. That's just kind of the way it is. They would want me to talk to the husband, and then the husband would talk to the wife. I'm not supposed to communicate directly. That can create obvious communication problems. I've been on runs where they've for religious reasons, they've asked me to leave my boots at the front door. And again, that's a PPE thing. So no, I can't do that. They can walk out to me. But trying to be respectful the best you can within reason is something that we're all going to be kind of tasked with doing. So I'm going to skip through some of that. This gets way down in the weeds, and I don't care about any of this stuff. Again, PPE is still going to prevail. I'm not going to show anybody the bottom of my feet to come into their house. Just dumb. This is what it is. If you avoid eye contact, cool. If you can sense that it's super odd right now, there's a weird tension in a room. Again, just try to get them out into your environment. Once they're in your ambulance, they're kind of out of their comfort zone already, and it's a little bit more acceptable for us to be able to go through and do what we need to do for the assessment. So this gets super weird. This is the essential oil conversation. If somebody's having a heart attack, you use eucalyptus oil, or somebody's got a stroke, you pump them with some ragweed. There are some of the weirdest stuff. Sticking an ice cube in somebody's butthole for an overdose. If you haven't heard that, that's a thing, and that's the thing that actually happens. And to be honest with you, one of the funniest runs I think I've ever had was I had a coworker that actually, with a straight face, and I don't even know how he did it, that they literally shoved an ice cube in a guy's rectum. We found him in a bathtub. He was overdosed, and I kid you not, with a straight face, the guy was so proud of himself. I took this ice cube, and it was hard, man. I couldn't figure out how to get it in there, but I got it in there. And he said, with a straight face, my partner looked at him and he goes, "Oh God, you used ice, didn't you?" Yeah, I used ice. He goes, "You need hot sauce. Hot sauce is the rule. You're supposed to shove hot sauce in there. And no kidding, there was a whole conversation about which brand works better than the other. So again, traditional folk medicine, everybody, there's an essential oil for everything. So God, just have some patience with these people, specifically with different cultures, because there is some concoction on the stove that's used to treat pretty much everything. So be very cautious as you're dealing with this, because whatever roux they've got cooking on the stove could have anything from fentanyl patches in it to straight CBD oil and all the other stuff. So just keep that in the back of your mind. People try to treat themselves in some weird ways.
I heard the large whiskey cubes work the best for that.
Is it? Write that down. That's going to be a test question. Whiskey cubes. Whiskey cubes is better than ice, which is better than, for God's sake, you put Tabasco in somebody's butthole. That'd be terrible.
Frozen chicken wings is the best one.
Which one?
Frozen chicken wings. I'm not even kidding.
Frozen chicken wings.
Yep.
I don't remember reading about that. That's cool. Where do you work?
That's in the second book.
Oh God, I didn't get there yet. I'm sorry. God, I'm behind. I didn't prepare appropriately. Well, there's that. So yeah. So some of the other weird stuff. This cupping, coining. This is all physical stuff. You can see this. Cupping, hell, they're starting to come to the point now where that's an actual thing that they're using for athletes. It's a whole nother story. Coining, if you're not familiar, is heating up coins and literally putting them on skin and burning the tissue in circular patterns. Cigarette butt burns, stuff like that. There was a history recent, not too far past, of dipping kids super hot water, trying to get them to stop crying, as if that made any sense in the world. So there would literally be circumferential burns distally where they put them in hot water. It's horrendous. How cruel people can actually be it blows your mind some days. But just know that there's a bunch of weird non-traditional treatments that are out there. Language interpretation, we talked a little bit about Google Translate. All of our ambulances, or at least most of our services, should have some type of AT&T language line, which is basically you call them and say, hey, I need a Spanish translator or whatever, and they will call from a call list, and they'll patch in a Spanish translator to you. The biggest thing for testing purposes, if you have a language interpretation system involved, you have to speak directly to the patient as if you're speaking directly to the patient, even though you're technically talking to the translator. So if I say, ask her if she has chest pain, literally the interpretation will be, hey, ask her if she has chest pain, and then back and forth. So they will repeat verbatim what you say. So this mediary person is just that. It's just a mediary person. You're still talking directly to the patient. So please try to keep that in mind. That's not really a big deal until it goes to court. If a run goes to court, they're going to pull the transcripts from language line, and that is a very, very weird, conflicting transcript to try to read through when everything's in third person. And that's really it. So as far the last little piece on the language interpretation thing, if you don't know language line, you can say, hey, I don't know what kind of gibberish this guy's talking, but he's got some kind of gibberish. Can you figure it out? And they've got some way of doing that. Google Translate, if you get down into some of the settings, there is a way for you to set that to auto detect. It's a little bit slower, but if you can set it to auto detect and have them say some kind of whatever gibberish, it'll try to pick out some of the words and try to give you an idea. That way you can go back and set it to the appropriate language, and then it'll speed it up from there. But again, if I were you, the Google Translate system, it's not super well organized with when you're saving phrases. But if you think about a run chronologically, hi, my name's so-and-so, I'm a paramedic, what's bothering you, what hurts. If you start going through chronologically the run and start typing that into Google Translate, so hi, my name is whatever, hit search and then save that. And you can what you'll end up doing is you're going to create a chronological list of things in order that you would typically ask on a run. And then car wrecks in general are good because that can be interchanged with any other trauma. So somebody fell off a roof. You can still ask them the same, does your head hurt? Does your neck hurt? Does this hurt? Does it hurt to breathe? All the same questions that you would ask a car wreck patient. So if you think of car wreck patient and then you think of like the major, like cardiac and respiratory, those 2 runs, if you can think of the questions that you would typically ask and start saving those, that'll allow you to pull them pretty quick. All right, that's what I got. I don't necessarily want to move into documentation today. We'll catch up. So we're only down a documentation chapter, which, by the way, documentation is only, I don't know, it's not very long at all. Yeah, it's not very long at all. So we'll be able to catch that up real quick once we get into next week. I want to let all this A&P stuff kind of fizzle out because right now A&P is probably on the brain. I've had quite a few of you ask about study sessions, trying to get together and try to tie up all the loose ends of the first couple chapters. Everything from here on is physical, tangible stuff that we've already been exposed to. So when I tell you that the patient's having a heart attack, you've probably seen a heart attack patient. You can picture what that is. You can picture how that goes. You can picture where they need to go. You know that there's a monitor involved in vital signs. When I start talking about mast cells, you got nothing. There is no ability for you to connect that unless you've had some kind of microbiology class in the past. There's no way for you to connect that with something of the past for memory purposes. So that's why everything that you learned today and Monday we're going to skip because you probably already forgot Monday, but last week, all of that stuff is going to skip your mind probably in the near future, just because, again, it's not stuff that we use. It's important for us to present it though, because I do want you to kind of understand how that stuff kind of reacts in the body. My final words on the IG and the mast cell system, because again, there's videos that all kind of suck, but there's a lot of reading material that's outside of the book. If you just did a Google search for IgE versus mast cells, there's some really, really plain language stuff. And really what they're going to tell you is that the IG and the mast cells they're like the Navy SEALs of the immune system. They're the high level that once the other cells can't determine what it is, once those T cells can't figure it out, they call in the big guns, and that's that IgE system. So those high level operatives are going to go out there and try to determine what the hell's going on. So that's usually when that allergic reaction response happens. So the last few days, we know that carbohydrates and protein, they convert into glycogen or glucose in the body. Glucose changes into ATP, and ATP is what makes our muscles work. So that's a recap of the first day or the first couple days. Shifting gears, as far as the immune system is concerned, we know that the body is constantly hunting for things that are antigens that are not normal. Those T cells are constantly out there looking. They're constantly looking for something that's not one of them. Once they find it, they trigger the B cells to create an antibody. The antibody finds the antigen, connects it, makes a complex. That complex is then wiped away by a white blood cell. If you got that, you've got 60% of what we've talked about figured out. If that doesn't make sense, we need to talk. We just need to rehash some of it. pH, the acidosis and the alkalosis. If you understand that 7.35 to 7.45 is the normal pH range in the blood, you'll know that that's normal. Anything less than 7.35 is acidotic. Anything over 7.45 is alkalotic. You'll understand a majority of that. The last two little pieces, if you understand that carbon dioxide that's exhaled in the end tidal, in the world of end tidal or capnography, if you understand that that is physically measuring acid, then when that number is low, when they're breathing at their end tidal is 5, then we know that they have blown off 100% or almost 100% of their carbon dioxide, because there's there's only 5 millimeters of mercury that's physically registering. There's only 5 instead of the 35 to 45. So why that all happens, we'll get into later, but understanding that a low end tidal is the alkalotic world and a low pH is the acidotic world. Understanding all of that will put us at that foundational level that I needed us to be in. So again, if all of that is Greek or gibberish, we need to chat, we need to talk, get with me at some point and we will figure it out. But if all of the other stuff, it's all kind of a blur, we're still good. We're still good. I promise. Once we get back into respiratory, we'll talk again about the alveoli stuff, and we'll talk again about kind of how that oxygen and carbon dioxide flip flop in the alveoli. We'll talk about a lot of that stuff again. So this was just a bird's eye kind of view. I happen to go a little bit deeper in certain areas because there's some of this stuff that I want ingrained in your memory now, so that when it comes up, it is an automatic thing. Like, yeah, I get that. I've heard that before. I totally understand it. So that's really about it. Anybody have any questions? I think my phone's ringing. That's cool.
Adam, we get a chance. I'll talk to you once we get a moment. Once everybody leaves. Adam.
Yes.
Adam.
Yes.
When you get a chance, when everybody leaves, can I have a moment? Can you hear me?
Yeah. You just need a minute.
Yeah, I just need a minute with you when I get a chance.
Yeah, that's cool. Just hang out. I'm done for today. If nobody has any questions, we're good. And again, the biggest thing is if this stuff doesn't make sense at all to you, I need to know. And that's really it. Cody, what you got?
This book came in. Is it worth even trying to read it, or should I wait for like cardiology or something?
That book is the best book you can ever get as it relates to cardiology. And if you get into that, if you have a good understanding of the things that we just recapped, if you've got a good basic fundamental understanding, there's nothing that's going to stop you from getting ahead by reading that. I will say that a lot of the stuff that it talks about is not stuff that you're going to be tested on. So if you know yourself and you know that you're going to get flooded with information and overwhelmed, I would maybe hold off. But flipping through it is not going to hurt anything whatsoever.
Okay, because yeah, I'm not the smartest, so yeah, I may. We'll see.
Oh, stop! No, you're good. You're good.
Even if like just looking at it will give you so much better of an understanding on just like muscles in general too. Think about like whole body aspect. Looking at it, it'll literally break down like electric systems, everything. So don't take it all in, but it's a great book so far.
That makes sense. If you guys weren't part of that, the Rapid Interpretation of a 12 Lead is the book that he's talking about. It is kind of expensive. It's like $30 or whatever. But I physically still have it, and I still physically refer to it. It's phenomenal. It's awesome, and it's very, very simple. It breaks it all down really, really nice. If you didn't buy it, you're fine. I'll still take care of you. We'll get it figured out. But if you did buy it, the time that you absolutely have to get into it is right before cardiology. Now you've got some time before now in cardiology. We still got to get through the respiratory system. So again, try if you're going to lose something to put that into your brain, it wouldn't be worth it. But again, just for reading material, it's pretty awesome. What else? Anybody else? Nope. All right. Well, I will see you guys. Well, I won't see you Saturday, will I? Well, I will see you next week then. You guys enjoy thyselves. I'll be around. I'll be around this afternoon as usual. With the
Adam, I do have one thing.
Yeah.
Are we going to take the quiz then for patho and communication on Wednesday morning?
That's a good call. I'm gonna probably combine them into. No, I'm gonna make them separate because I want you guys to get the benefit of having two different grades. So yeah, we'll do two quizzes next week. So on Wednesday, you'll have a chapter 9 quiz, and then you'll have that chapter 5 communication quiz. I do want to reiterate. I understand that some of the grades. First and foremost, I spent way longer than I should have on that cardiac ordering question that was on there. And then I totally somehow blanked on putting the key in. So it was a complete waste of everybody's time. And for that, I apologize. But that needs to come back to you guys. So I'm gonna get that'll be on the next quiz. And for that matter, moving forward, a lot of the information that we've tested on already will be, I'll bring that back in future quizzes. Again, the quizzes, this is not the intent's not to fail, which is why there's that equal weight between the homework assignments. So just kind of keep that in mind. If you didn't do super awesome on that quiz, it's no big deal. If you look at your grades, everybody's still in like the high 90s. So I wouldn't worry about that. As far as that's concerned, I sent an email about that one particular test question. I added five points to everybody's quiz grade for that, just to be fair for that cardiac question that I messed up. So so next Wednesday, so between now and next Wednesday, we didn't do anything with Chapter 9's submissions for the learning objectives, and I'm hesitant to do that because really there's a lot of them, and a lot of them are some of the finite things. Actually, there's 27 of them, and of the 27, there's not really a whole lot of them that I really want. So here's what I'll do. So on the chapter, and honestly, I didn't look at chapter 5 yet, so give me 2 seconds. Geez, chapter 5 has like 29 of them. I don't like that either. Here's what we'll do. Stand by. I will send an email out today with it'll be just a message that says jump into Schoology, and I'm gonna pick a few of them out. There's no reason I don't want you guys to do all of those on either chapter. So I'm gonna pick out a few of them that I know will either be tested on by me or tested on by the registry or FISDAP, and then I'll have you guys submit those just like we have been. But again, don't do all of them. If you choose to do all of them, hats off to you. It's not going to hurt, I promise. So if you have the time to do it, please do. But I will give you the minimum required ones, and then you guys can submit them by next Wednesday. So you'll have chapter 9, chapter 5 homework, and then you'll have chapter 9 and chapter 5 quiz next week. Fair? Awesome. Well, you guys enjoy yourselves. Have a good weekend. Stay safe. Stay dry. And Thomas, if you want to stick around, I'll hang out with you for a minute. Adios.
Be crest out.